Heidi.
Okay, I got plenty of experience. Heidi. Okay, I gotta remember. Same as my daughter upstairs. Okay.
Uh,
And
it's
Sarah, but I don't. We don't have her name right. She pronounces it different.
Sara.
Sada?
Uh-huh,
yeah.
Sara. That's how Latino people say it too.
Really?
Yeah, Sara.
S-A, like S-A-D-A, Sada.
Sara.
Almost, yeah.
Sara.
Sada.
Sada.
If you Sada.
Sara. Right?
Sada. Like saw, S-A-W-D-A,
Yeah,
I think.
Sada.
Yeah, Sada.
Yeah. So you're you said your daughter's here upstairs?
My daughter works here. My daughter works here for,
Oh.
has worked here for many years.
Oh, at the school?
In the dental school.
Oh, in the dental school.
Yeah.
Oh.
She's
Like-
on the fourth floor. She has something to it. She works with accreditation and all that stuff. Her name is Heidi Cooley. You know, you probably don't run across her anymore because she works.
Okay. Oh, her name's Heidi also.
Yeah, her name is Heidi too.
Oh.
Yeah, Heidi Cooley.
I think we might have heard her name. Like.
Yeah, she works. Right now she's working. Who's one of the new academic? She's a new assistant dean.
That Miss Ford.
No. Would she change her name?
Oh
Ford
yeah.
did?
Yeah.
She changed her name
From-
to Ford?
Yeah, to Ford.
Oh, okay.
Valenzuela.
What was her last name before?
It was
like-
Valenzuela.
Yeah,
Venezuela.
Yeah.
Yeah. No, they're gonna be in the office now upstairs on the fifth floor in that corner. So she's the one that has to do with all the accreditations. So she's one of the assistant Asian person has this, my daughter now works for her. Yeah, but she works all these accreditations for like the grad programs and you guys and hygiene and all that stuff. So she does that type of thing.
Interesting. That's cool. And you have 3 daughters?
I have three.
3. Oh.
Three that starts with H.
With an
That's why
H.
I called her
Yeah.
Heather. Well, I could have called her Holly,
Oh yeah.
which I probably will for this time.
Heather, Holly, and Heidi.
Yeah,
Wow. 3 girls.
3 girls, and there's 2 boys too, but they don't have similar names.
Oh.
I was smart to keep them out.
Okay.
So, let's see, how are we doing? Oh, Sada should be here in a minute.
Oh yeah. Should we?
You know, it's amazing when you think what she has done. That is amazing.
I know.
Yeah.
Oh,
She deserves an award, honestly.
she does.
Yeah.
You gotta give her a lot of credit. She's got a lot of guts, I'll tell you.
Yeah. I mean,
I don't think
You
I'd
know?
be able to do that.
not being able to speak one word English.
Just get dumped in another country?
Yeah.
Yeah.
I was hearing what she got, like her, what was it? To get here? It was like it was like a raffle thing, right?
Oh yeah.
Yeah, they say that it's really rare to get that.
Yeah.
To get the raffle.
Really?
Yeah, they say that it's really rare, and that like 1 out of something.
So she got that, she came here because she got something
Yeah.
like that. There were
Yeah.
so many people and
Yeah.
her number was pulled.
Yeah.
Yeah. Like lottery.
But I find it interesting she's going back to Iran.
Oh yeah, because she says it's too stressful here.
Well, that's because she's in Southern California.
Yeah. I don't think it's that stressful. I mean, we're in school right now, but yeah. Overall, it's not too stressful. I think it's just because, yeah, she's just, the whole culture
Yeah.
is different to her.
So, Dr. Richards did say that I could change quizzes and stuff if I wanted, so I do have the
Hey,
okay to
Sarah.
do
Hey. We're here, on the same spot downstairs. No, we're waiting for you. Okay. That was just Sarah.
So you said that you could change the quizzes around, or?
that. This I could change them a little bit.
Oh.
Like the quiz you guys have today, the pre-quiz.
Mm-hmm.
She says, what are the best 2 answers? She gives you a possibility of a lesion and said, what's the best 2 types of diagnosis? Wait a minute. That all depends who's answering that. I would answer that totally different than she would. So how much latitude do you have for the answers? You know what I'm saying?
Mm-hmm.
Yeah.
I mean, she says, what's the best two? I can easily name 5. Okay, who's going to choose the top 2? I may choose my top 2, and she may choose her top 2. So I find that difficult.
And that's like what I struggled last quarter, or the quarter before, because I would put like the other one.
Yeah.
I thought it was.
Right. So
And so
I
did
find
that
it,
wrong.
I find that hard. Um, I would say, what are 2 reasonable diagnoses? What are reasonable ones? Okay, instead of the top 2. Does that make sense?
Mm-hmm.
Because there's more than 2. There's more than 2 reasonable ones.
Mm-hmm.
So when she says, what are the top 2? And what she mean by a diagnosis? Okay. If it's a white, let's say a patient had a white lesion and on the tongue, okay? It's been there for 6 months, and let's say it's a centimeter in diameter, elevated white lesion, okay? Doesn't rub off, so we know it's not candida, okay? And we don't see anything there that she's biting the area, okay? So then if I said, what's the 2 most likely diagnoses, what would you put?
It's a white lesion. It's a little
Slightly
elevated.
Yep.
But there's
wipe
no.
off.
Oh, it doesn't wipe out. There's no source of like.
We don't know what's caused it.
Oh, we don't know what's causing.
Let's just say that we know the patient's a smoker.
Okay.
So what would be likely diagnoses?
Wait, that she's a smoker?
Yeah, if it's a smoker.
Would
Let's
it
say
be?
the patient is a smoker.
Oh,
So if I said,
Yeah,
what are
that's
2 most likely diagnoses, what would you put?
verrucas? No. I don't put that. I
Well,
was thinking verrucas, carcinoma, but I don't think that's on the tongue.
Not usually.
Sorry.
Hi, Sada.
Hi. Good morning.
so something that has to do with smoking
Could
Is
be related to smoking. Yeah, let's just say the patient is a smoker.
could be carcinoma in situ.
Could be. Okay, that's a possibility. All right,
Yeah.
because carcinoma in situ could be a white lesion.
Yeah.
Mm-hmm.
Carcinoma in situ could also be a red lesion, right?
Mm-hmm.
Yeah.
Yeah. And the only way you would know it's carcinoma in situ is by what?
By the color of it?
No, the only way you could prove it. What's the
Biopsy.
only way you could prove it?
Oh, biopsy.
Oh, you'd have to have a biopsy,
Biopsy.
right?
Can I just write that on really quick? Can only tell if biopsy.
No.
So okay, so you gave me, so it's a white lesion, you said carcinoma in situ. I would have to say, okay, I gotta give you credit for that,
How
okay?
about benign keratosis?
Benign keratosis, okay, I'd have to give you credit for that,
Okay.
Mm-hmm.
because it could be, okay? So what are some of, so those are 2 possibilities.
Yeah.
How do you know those are her possibilities that she wants? Because name some others, what are other possibilities?
Epithelial dysplasia.
Yeah, yes, it could show epithelial dysplasia, yeah.
Okay.
So epithelial dysplasia would be a microscopic diagnosis.
Mm.
Okay?
Mm-hmm.
So, but you're still not, okay, if this is a white lesion, and she says, what are the 2 top diagnoses? When I see a white lesion, if you saw a white lesion up in the clinic and you came and called me and said, hey Lane, I want you to come and look at a white lesion. I said, okay, Brian, what do you think it is? Clinically, what do you think it is? Well, what would you call it, Brian? And you may say what? What's a clinical term for a white lesion? What's in your notes?
Leukoplakia.
You may say leukoplakia, right?
Yeah.
Would that be wrong, then, for an answer of what the questions that I was just asking you?
Yeah, because isn't that just like a description of it?
It's a diagnosis.
But she said, what's a diagnosis?
Uh-huh.
A clinical diagnosis or a microscopic diagnosis? She didn't differentiate.
Oh,
She didn't differentiate between the 2,
that's true.
right?
Yeah.
So leukoplakia is a clinical. It's a diagnosis. Well, it's a descriptive term. It's a clinical term to describe a white lesion.
Mm-hmm.
So I'm thinking, thing I would put would be leukoplakia. But would I be marked wrong? See what I'm saying? That's where I have a hard time. That's where I say, hey, what do you think this could be? And I would say there's more than two answers.
Mm-hmm.
Yeah. But if I had to pick the top two diagnoses, how do I know what the top two diagnoses are?
Yeah. So, yeah. So are you letting us kind of choose two answers if it comes to that? If it comes down to that?
That was my question too, because I can't figure it out which one is side 2, which one is benign, which one is the other one, keratosis.
As far as what?
If we see a lesion
Yes?
picture
Okay.
and then pick one of them, so I don't know the difference between.
When you see a lesion, you don't know what it is.
Yeah.
There's no way to know.
But she
Maybe-
always asks about side 2, about keratosis. She asks which one it is.
But you don't know what it is until you have a biopsy. You may have ideas. You make a differential. A differential diagnosis is naming several possibilities, right?
Okay, yes.
But definitive diagnosis only can tell from a microscopic description.
Description.
Mm-hmm.
Now, did I answer your question?
Yes.
I mean, you can't look at a picture, but I can. Now, some things I could look at. I could look at something, and if it had the really characteristic of a malignancy, like if it was a nasty looking lesion that was ulcerated and been there for 6 months to a year, and it was exophytic and ulcerated, I say, hey, that's a nasty looking. Most likely it's squamous cell carcinoma.
Yeah.
Okay.
You can't prove that. You know what was an interesting thing? In last February, at the Alumni Student Convention, there was an oral path lecture by an oral pathologist, actually, who wrote the big path book you have. He was here lecturing. And he said, I'm going to show you some pictures. And I want you to all stand up. And when I show you a picture, you decide in your mind if it's benign or malignant. Okay?
Okay.
You decide that
Okay.
ahead of time. Once you decide that, I'm going to tell you what the diagnosis is, whether it's benign or malignant. If you're right, stay standing up. If it was malignant and you thought it was benign, and I said benign, you need to sit down.
Mm-hmm.
I will guarantee you, after a few, none of you will still be standing.
That means most of the time it's not benign. It's
No, most of the time it's saying we don't know.
we don't know.
Oh. We have an idea, but you don't know. So after a few times, when the person's standing up.
Okay.
Because we don't know looking, sometimes you have an idea. If I see a squamous papilloma, and it looks like a squamous papilloma, I'm 95% assured that it is a squamous papilloma. It doesn't have the characteristics of a malignant lesion. But I've seen squamous papillomas that were a little abnormal that were squamous cell carcinomas. Okay, so the only really proof
It's biopsy.
is biopsy. But by knowing the characteristics of the lesion, you somewhat have an idea. That's why we do a differential diagnosis. A differential diagnosis, what is the most likely? What's the most likely lesions? All right.
Yeah.
Mm-hmm.
So if I say a red lesion,
Mm-hmm.
and you had a red lesion on a patient, okay, and let's say it was about 1 centimeter in diameter, you didn't know why it was there. Maybe the patient's a smoker, maybe he's not a smoker. What would be possibilities as far as for either a clinical diagnosis or a microscopic diagnosis that you would think of?
Erythroplakia.
Yes, erythroplakia would be one. Erythroplakia means red and white,
Red.
but if there was no whiteness to it, only red, what would you call it? Erythroplakia.
Yeah.
So there is a term, if they're red and white, it's called erythroleukoplakia. all right?
Yes.
A clinical term for that is speckled leukoplakia.
Yes. Speckled.
Speckled means red and white.
Red and white.
Right.
Yeah.
So, I mean, you can have white lesions, you can have red lesions. Most red lesions that we see in the mouth are inflammatory, irritation. They don't show, premalignant characteristics, okay? So what is a clinical term for a red lesion that's not inflammatory? That is premalignant lesion. What is a clinical term? If you were to describe,
Dysplasia?
Yeah, that show dysplasia. What is a clinical term? Leukoplakia is a clinical term for a white lesion.
Yeah.
What's a clinical term for a red lesion?
Erythroplakia.
Erythroplakia. Now, let's say that the patient had a white lesion on the side of the tongue. We're talking about 1 centimeter white lesion on the side of the tongue. Let's say he is a smoker or he's not a smoker, okay? You biopsied that lesion, okay? You sent that specimen in to have it diagnosed for a microscopic exam. And what you get back is a path report. On that path report, it will give you the history, what you put as far as how old the patient is, and it's a history as far as what the lesion looked like. And also on a path report, you'll see these, it's a information of what the specimen looked like, it's what size it is and things like that. And then on the bottom of that report, it has diagnoses. So if you had a white lesion on the tongue, let's say it was a little elevated, it was white, did not wipe off, and you did a biopsy on it, when that path report comes back, what are the diagnoses that could be on that path report?
Benign keratosis.
Benign keratosis, right, good. Yeah, and most likely, most of these white lesions are benign keratosis, okay? That's one of them. What else?
It would be...
It's a white lesion.
Yeah, it's a white lesion, and it can be speckled as well.
Or epithelial dysplasia.
Epithelial dysplasia.
Yeah.
But, okay, but one thing here, could be epithelial dysplasia, but be a little more specific, because I said it is a white lesion. So you said dysplasia, which is correct. Dysplasia means what? Dysplasia means it has abnormal cells within the epithelium. Okay? But I also said this was a white lesion.
Keratosis dysplasia?
Keratosis with dysplasia. Right? So she said benign keratosis. Saya said keratosis with dysplasia. Okay? You name two. Name two more.
Of what it could possibly be?
What it could possibly...
Could it be a squamous cell?
Cell carcinoma.
Yes. Could be a squamous cell carcinoma. Okay? So you named three. Name one more. It's in between.
Early invasive?
Verrucous carcinoma?
Carcinoma what?
Verrucous?
In situ.
No. Well, could be.
Okay.
Could be. I mean, that's possible.
Situ is
Verrucous
red.
carcinoma is
No,
not very
it's white too?
common. Not very common. And usually it's in older people who have actually chewed tobacco for years, or used to be then. Yeah, we're gonna look at verrucous carcinoma. Okay, so you missed one other thing.
Yeah, one of them left behind.
So, what if, okay, you said keratosis with dysplasia.
Yes.
And it would say, if you get the biopsy report, it's gonna say keratosis with mild dysplasia. If there was only mild, that means some of these cells are abnormal. Or is it keratosis with moderate dysplasia, if more of these cells show abnormality?
Severe.
Or if a lot of these cells within the spinal cell layer show dysplasia, it's going to say keratosis with severe dysplasia. Okay? The next step, as it progressed, would be invasive squamous cell carcinoma. But there's still a step between those two. There's a step between keratosis with severe dysplasia and invasive squamous cell carcinoma. There's a step. And that's when all the in the epithelium, all the cells are dysplastic, but they haven't started to invade yet. What is that called?
Carcinoma in situ.
Carcinoma in situ. Does that make sense now? Now, let's say it wasn't a white lesion. Let's say it's a red lesion.
Red lesion.
Okay? So if it's benign, it could be just inflammatory. But if it had some abnormal cells, what would be the microscopic diagnosis?
Carcinoma in situ.
Could be carcinoma in situ,
Okay.
or it could be, what's the step before that?
The dysplasia.
Just
or-
dysplasia.
Yeah.
Great. So dysplasia, carcinoma in situ, and the step after that would be what?
Basal cell carcinoma.
No. Not basal cell doesn't occur in the mouth.
Squamous cell.
Squamous cell
So-
carcinoma. Is that making sense what we're
Yeah.
saying now?
Squamous cell.
Yes.
So like, okay, as it like progresses, it gets
As
to
it progresses,
squamous,
right.
Squamous cell carcinoma.
Now, let's say,
What was the first one before side 2? It's dysplasia. No.
well, yeah.
Yeah.
Well, the first one,
Yes.
if it's red, it could just be inflammatory.
Okay.
Would have no dysplasia. Could be
Mhm.
some irritation.
Got
Okay.
it. Yeah.
And if it doesn't have any keratin on it, it's just a red lesion. So a lot of red lesions are just due to inflammation. Okay? But they don't have any dysplasia. So dysplasia means what? These cells take on abnormalities, different abnormalities. Okay? Now I lost my thought. What was I going to say?
For the white one, we said it's keratosis. For the red one, we can't say keratosis.
We can't say keratosis
What
because
we
it doesn't
said-
have any keratin on the
Yeah.
surface. But if it has some abnormal cells,
Just
it's
dysplasia.
dysplasia.
Okay.
So dysplasia could be mild, moderate, or severe. Okay?
Would we have to put epithelial dysplasia or just?
You probably would put epithelial dysplasia. Yeah. And actually, you make a good point.
Yeah.
The epithelial dysplasia.
Thank you.
Okay. Can I tell the difference if I looked at a lesion, whether if it's a red lesion, whether it's inflammatory or dysplasia? Looking at it clinically?
Oh, you can't tell.
No, you can't tell the
You
difference.
can, yeah, biopsy.
I may have an idea because of the history. What if somebody, and I'll show you something today, what if you had a red lesion that was there for a long period of time? But yet, there was no irritation, there was no reason to be an irritation.
Yeah.
Mhm.
You would worry about a dysplasia, right?
Mhm.
And dysplasia often has kind of a, it reminds me of the surface of sandpaper. It has a rough, granular surface to it. Yeah, you guys got a pretty good understanding, you do. I mean, you guys, I'm impressed, I really am, what you guys came up with.
I scared
Like, I
to
feel
fail
like
again.
we're good at it. It's just like the quizzes scare us, and then the exams. you
I'm
know?
not good at it.
Yeah,
No.
I think.
I
that's
scared to
just-
fail again, and then they kick me out of the school.
Oh, I won't let him.
Dr. Richards can do everything, But I feel so bad. They're not here like,
Looking at us like we get
yeah,
it.
I still need to look at this stuff. Some of them still here, but some of them no. I forget them.
And you guys don't have any color atlases you look at. Where do you see your pictures when you study this?
Yeah, it's like that's another thing.
We
Like,
don't have it. We just use the leftover about the seniors or about a
But do
year.
you borrow color atlas? I mean, there are a couple good
Yeah,
color
I have
atlases.
that stuff, but that's for seniors. Senior.
But the book, do you have a color
No,
atlas
no,
book?
no book. We don't have a book. Did you get the book? I don't have a book. That's the reason we ask you to borrow that PowerPoint with the picture, and you mentioned we can't do that because Dr. Richards mentioned don't
And
share.
I actually brought a couple color atlases.
Yeah.
And I was gonna bring one, I forgot.
Yeah, we
one,
don't
bring
have
it tomorrow,
pictures.
that you guys can use. You can run it back and forth, but there are two good color atlases, two good ones.
Mhm.
All right, and they're really pretty good. But I'm surprised you guys don't have one or access one. Are they in the library that you can check them out? I don't
Okay.
know.
Yeah, they're probably. Yeah.
They have it. Okay.
Yeah, I would, if you could check them out.
Okay.
All right,
When it's red and white. Oh, for the red we just have 3 choice, not 4.
right, well, the one fourth choice, if it's red, it could just be inflammation, right?
Okay. Yeah.
So you have inflammation, you have epithelial dysplasia, could be carcinoma in situ and squamous cell carcinoma.
Yeah.
Right?
Yeah.
Yeah.
That's a for the red.
Yeah. Okay. So,
But it's mixed.
yeah.
Espical. Something.
So do you work in the yard much?
Hmm?
Do you work in the yard much?
What is that?
Weeding weeds and stuff out in the yard? Flowers,
and
hoeing,
Gardening.
gardening. Do you do gardening? You
No.
don't have time. I know
No.
you don't have time. But if you did, if you spent a lot of time doing gardening,
Mhm.
what would your hands look like? What would you have on your hands?
Like
If- Like what?
blister things or
Not
some
well, blister
like a
if
scratch thing.
you would have a blister if you went out and did a lot of work in one day and didn't wear gloves. But what if you went? But what if you went out and worked an hour every day and you didn't form a blister? What would you have on your hands?
The scratch maybe? No, I don't
What do you
know.
have right? What would you have right here? And I don't have any.
Redness?
No.
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 The white.
The-
The.
It'd be a callus. Are you familiar with the term a callus?
No. What is callus?
Callus is a buildup.
Oh,
Of
it's gonna
keratin.
hard. Yeah,
Hard.
got it. Okay.
Yeah. Okay.
Yes.
Do you run barefooted a lot?
No.
No. But if you did,
Yeah, it's
you would
gonna
have
be
thick,
on a hill.
you would have thick calluses.
Yes.
Okay. So let's say you gardened a lot and you
Mhm.
had a lot of calluses, and then you were doing the dishes, or you soaked in a bathtub for 30 minutes.
Yeah, it's gonna be white,
It's going to be white.
but it's nothing.
Because why does it turn white?
It's keratin.
Because when
Of
a
the water.
callus, and what is that callus? That callus is keratin.
Yeah.
It's hyperkeratosis. It's dead cells that build up. Okay.
Mhm.
So if you soaked in the bathtub for a while, that callus would be white. So that's the same thing. It's just a buildup of keratin. So what areas in the mouth are normally keratinized?
Tongue on the side.
Not
and-
the side,
No.
not
Just
the
tongue.
side.
The tongue.
The dorsal surface.
Dorsal.
Dorsal means top. Okay. What else?
On a buccal too?
No.
No.
The normal keratinized areas in the mouth.
Gingiva?
Heather. I mean Heidi.
Yeah. What he said.
What'd you
maybe
say?
The gingiva.
The gingiva?
Gingiva. Okay.
Gingiva.
All right. That's two of them. So dorsal tongue, gingiva,
The palate?
and hard palate. And sometimes the lips can be keratinized. So what areas were more susceptible to dysplasia? If it was a smoker, are keratinized areas or non-keratinized areas more susceptible to dysplasia?
I'm guessing yes.
You're guessing what?
I say yes.
Yes to what?
To keratosis, that it turns white.
Well, yes, it could turn white,
Okay.
but what areas,
Oh,
whether a
is-
keratinized area or a non-keratinized area in the mouth, are you more likely to see a dysplasia or squamous cell carcinoma on?
The palate. Oh, squamous cell. Oh,
Would be the keratinized or non-keratinized? You don't name a specific
Okay.
area.
Keratinized?
Keratin. Because the cell
Where
gonna
are
die.
most most oral cancers found?
in the lip. The
If you
vermilion.
don't include the lip, inside
Okay.
of the mouth
It'd be
Palate.
the side of the
No.
tongue.
would be side of the tongue.
Yeah.
Is that keratinized or non-keratinized?
No.
No,
Keratosis.
Okay, so the most areas that are susceptible to dysplasia or malignancies are non-keratinized areas.
Yeah.
Right.
Okay.
Oh, okay.
Does that make sense?
Yeah.
Yeah.
Not very often. I mean, I don't say
In
you can't,
non-keratinized.
Yeah.
but not very often do you see squamous cell carcinoma of the gingiva. You do find it,
Yeah.
but it's most likely it's going to be, either the lateral border of the tongue, or what is another area in the mouth that's non-keratinized that's very susceptible to dysplasia? You didn't name
Gingiva?
it.
The
Huh?
base,
Gingiva?
yeah.
No, gingiva is keratinized.
Keratinized.
The base of the mouth.
Yes, the
bottom
floor of the
of
mouth.
The floor,
The floor of the mouth.
Yeah.
So the high-risk areas in the mouth, what are the high-risk areas for malignancy?
So it'd be the lip.
Lips,
The lateral of the tongue.
lateral of the tongue,
Base of the tongue, or the floor of the mouth.
the floor of the mouth. One more.
I'd say the buccal. No.
Not usually a high risk area.
Okay. What Sarah said, the gingiva.
But it's
Gingiva is
keratinized.
keratinized.
Oh yeah, keratinized. The top of the mouth.
Where?
The palate.
Dorsal
Front?
palate. No, on a soft
Dorsal.
one. Yeah, dorsal. On
So-
a soft palate.
On soft palate.
Okay.
So those
palate.
those
yeah.
are the high risk areas.
Mhm.
Okay. This is fun, isn't it?
Yeah.
You guys learning it.
Yeah. It's clicking.
Yeah,
Yeah.
it is. It is clicking. Yeah. Are you ready for your quiz?
Okay.
Yeah.
And after quiz, you're gonna teach us more about this? Yeah?
Am I doing what?
You're gonna teach us about epithelial
Yeah.
lesions? Still?
Yeah.
Okay.
We won't get through the whole thing today.
Yes, okay.
But we will, tomorrow we'll finish it.
Okay.
And then we'll do pigmented lesions, which are not, there's not too many of the pigment, there's about 6 or 7 of them. Okay.
Oh,
We have 2 quizzes tomorrow. The post.
yes, then
and the pre.
post
Yeah,
for
so
the
you have-
skin.
You have a quiz on what we did last week?
Yeah.
So you guys are studying all the time, aren't you?
I didn't get 10, I got 7.5.
Yeah.
Thank you.
Me too, dude.
That's awesome.
I steal this.
Oh, wait, we can't do this until we look this up.
Yes.
Oh yeah.
Do you have any other questions while I'm hooking this up?
Oh, one more. Papule. So when we palpate it, it's hard or it's
A
squishy?
papule just means an elevated area.
Oh, it's not a name of something. It just
Right, it's just, right. a
characteristic.
It's an elevated area. a
And
papule.
it's hard when we palpate it?
Not
Is it
necessarily.
squishy?
It's just an elevated, papule is elevated.
Elevated. Okay.
A macule is a discolored area that's flat.
Macule is flat. Okay.
Like, a macule is like that, or that's a macule.
Macule. Got it.
It's got
Discolor
very
but
papule.
flat. Okay.
Well, you can't get much sleep up. I have a hemangioma on my arm here. That would be an example of a papule.
Interesting.
Miss Hayton mentioned to say hi to you. Shelley?
Pardon?
Shelley say hi to you.
Shelley who?
Shelley
Oh,
Hayton. Yes.
Huh.
She's in a hospital because her daughter, she's in a labor. Labor
Oh,
today.
okay.
We don't have a class after he.
Oh, we don't?
We don't have a class at
Oh,
10
wow.
because
I was like still studying for that.
her dad is in the hospital too. Her dad is not okay that much though, but
Oh,
Dang, okay.
yeah,
that's sad.
that's sad. Yeah.
Yeah, it's like.
So Shelley's gonna be a grandmother.
Yeah.
Oh, okay.
Actually, she's grandma too.
Oh, is she
but-
already?
Yeah, I think it's a third one.
Oh, okay.
The
'Cause I
fourth
know-
one is
I don't
coming.
remember I remember Shelley's son, or sons. I don't remember the daughter.
Yeah, Brian, we don't have a quiz.
Oh, thank gosh. Okay.
Yeah. I was studying autism and then I let it go and then I started.
Oh, then it
Path.
started path.
So are you saying if we run over a few minutes today, that's not a problem?
That's not a
No,
problem.
we don't have a class.
Oh, that'd be great.
There was one thing to
Okay.
study for tomorrow because I have patient today.
Okay.
Do you
Yeah,
have
patience,
clinic?
Yeah, I have clinic.
1:00.
You guys, you have
Yeah.
clinic too?
Yeah.
I think
Tomorrow
a
morning
lot.
too? We have a lot.
I don't have it tomorrow, but yeah, a lot of people have it today.
I have tomorrow morning too.
All right, here we go.
Okay.
Well, maybe we go. All right. Why did that do that? That was weird. All right. Weird.
Wait,
What'd
did you
I
see
press?
something? Does that help?
Yeah,
Okay.
but why do I have two I don't want number 3 on there, but it's alright.
And it's number 2. Where is 1?
Why is,
Now
what's
it's
alright
one.
here?
Yeah.
Oh, you got it all right here. Alright,
Okay.
so this is 1 and 2.
Oh, this is 1 and 2?
This is 1 and 2.
So there's 2 answers to this.
Yes.
Solitary painless lesion is one of all.
So this is what I was talking about, which 2 best diagnoses on the top of your, she's asking for a differential diagnosis.
Mm-hmm.
So is she asking what are the 2 best diagnoses? Microscopic diagnoses or clinical diagnoses? There's my question. See what I was saying before? So I'm confused.
Is it white and pink or it's all red?
Well, look,
Mixed? I think it's mixed.
actually, this patient wasn't a male smoker. It was a female.
Female
I
smoker.
remember I took this picture. This is my patient,
Oh.
but I know what the diagnosis was.
But, okay. This is my question. Oh, wait, it went already.
Oh, why did you do that? Oh.
Yeah, because it has a timer on it.
So I guess what she's really asking for is, what would be the 2 likely? I don't know. This is. See, I can name several things here. Well, I'm gonna answer it too.
Solitary painless lesion was one. What are the 2?
It's on a dorsal palate.
No, this is a soft palate.
It's an soft
So
palate.
this is the ridge.
Ridge, yeah.
So her denture went right here. This is behind the soft. This is behind the denture.
Yeah.
This is the soft palate of this lady. She was a 55-year-old heavy female smoker.
So that means.
And it wasn't an easy lesion to see. I was proud of the dental student. It was a gal dental student, I remember, who said, "Come and take a look at this lesion." Yeah, and it was a good exam that was done. A lot of people would have missed this.
Yep.
So I think she's asking more for a microscopic diagnosis than a clinical diagnosis, I think. I mean, that's why I have a very hard time with this question. I put 7 answers. And I'll argue those with anybody.
Okay. So then.
So when she says the two best diagnoses, I'm sure she's thinking of what would the microscopic diagnoses be. Does that make sense?
Not like a description to
Not,
it.
not like a clinical diagnosis, but yeah.
Okay.
Because like we said before, a clinical diagnosis is not a microscopic diagnosis.
Yeah.
Yes.
So she wants a microscope.
I'm sure she's asking for the
So my
microscope.
question is, we count this image red or white and red because it has
You
pink
have
in
to
the middle.
decide.
I think it's pink. It's mixed.
We,
Because
we never call lesions in the mouth pink. That's a woman's color.
okay, white and red. It's mixed.
Yes,
It's not. It's mixed.
I think it is.
Okay.
But is that a clinical diagnosis or a microscopic diagnosis?
It's not a microscopic. It's clinical. No.
Yeah.
It's clinical because we don't have a microscope, so we just see it. Clinical. No.
So
Well, that's why
yeah.
this question is confusing to me.
I'm so. Awesome. Can you count as two? More
Alright.
awesome.
Okay, next. I could name 4 things here.
I can name 2 things.
But she's asking, but would she grade it as what she wants?
Yeah, what she wants. Yeah.
That's different than I would argue.
Mhm. That's why a lot of.
Because you don't know what this is. I have an idea what it is. But
Outdoor gardening. She complains that her lips are always.
I would say
It's not.
what helps you there is she spends a lot of time outdoors gardening.
Mhm.
That should give you a hint. All right, you ready?
Mm-hmm.
4. No, I have one answer, only one. And it just throws it right into my face.
Is that that's the tongue, right?
No, that's the tongue. This is the anterior ridge.
Okay.
And where's the denture?
Okay.
I know, I took this picture too.
Oh, okay.
And then this is the lesion we're looking at right here. And this is the tongue.
Okay.
So try it
Okay.
right there.
Okay.
I have a question. So for the previous one, so we have, why we don't call it like a basal one, basal cell carcinoma, because it's on a lip. Why we don't count? Because if on the lip or here, it's gonna be actinic, but it's gonna be basal too because it's here.
Basal cells usually don't occur on the lip,
But we have a picture that it's on the lip.
but that's rare.
Oh.
Basal cells usually are not. You can have one. I have a picture of a basal cell too. But sometimes it's a combination basal squamous cell.
Okay.
But they don't usually, we don't think of basal cells being on the lip.
Basil's usually on the face.
Face.
It
Face,
looks like a
Got it.
mole.
Okay.
or something.
Thank you.
What's this, 4? Okay, I think, okay, 5 and 6.
What are two best types?
Okay, and we have a number 7. Alright, you guys finished?
Yeah.
Alright, let's go through.
Oh, what is the 8?
There's no.
We don't have
There
8.
is no 8.
Oh, okay. So I'm gonna finish.
Alright, put those away. We'll grade them after we go through the lecture, because then they will mean more to you, I think.
Okay.
Okay, take out your notes. And you have these same notes, right?
Yeah, we have it.
Okay. So let's go to the bottom of the page. We're gonna go through this fast. We're gonna look at some pictures here too. So, and she says epithelial lesions are derived from the stratified squamous epithelium, all right? And it says these are limited ways which epithelial lesions may present itself. So we know it could be a white patch, right? We looked at white patches. They can be a red patches. They can be a papule. papule is just an elevated area, okay?
Papule elevated,
It
okay.
can be exophytic mass. Exophytic means grows above the surface. Endophytic means grows down, okay? So other things it could be, and she has on the right-hand side, plus any of these with a non-healing. Could be an ulcer too, okay? A white patch is due to keratin production. We talked about, right? A callus, okay? So a white patch can be smooth, because we saw this one area on the quiz. There was an area on the side of the tongue where the white patch was smooth, and there was a white patch where it was kind of wrinkled and rough, right? So it can be very well defined. It can be irregular borders. It can blend into the tissue, solitary, multiple, okay? It says we cannot see the through the keratin, see if there's any abnormality underneath it down into the epithelial cells or connective tissue. So it's one reason, you know, one reason why you can't just do a cytology. Cytology is where you take something and wipe off the cells and look at these cells under a microscope. The reason you can't do a cytology on a white lesion is because all you're doing is getting the dead keratin cells, where the dysplasia is down in the epithelium under the keratin. Does that make sense? So you can do, did she ever talk about a brush biopsy to you guys in class?
No.
No, okay. So in the dental office, a lot of people, dentists, are doing brush biopsies. A brush, when I say it's brush, it looks like a little toothbrush with a minor toothbrush with very little small bristles, okay? So you go in the lesion, and it's only about that long, so it has these little bristles, and you do it hard. You go in the lesion, and go, the patient goes, ouch! And then you take these cells, knock these cells off, put them on a glass slide, and look at the stain and put them under a microscope. Well, when you look at these cells, you can tell if these cells have abnormal characteristics. That's called cytology. But that won't work on a white lesion, because a white lesion, you don't get deep enough. You don't get through that keratin. So you can't really do a cytology on a white lesion. You can do it on a red lesion. Does that make sense?
Yeah.
Because where the action is down underneath, right? So cytologies don't work on white lesions.
A white lesion.
White lesion. So the diagnosis of the white lesion is usually keratosis. Okay, benign keratosis, keratosis with dysplasia, all that. Cause of a white lesion, a lot of times it's rubbing. You rub something, okay? So if you keep biting your lip a little bit all the time, it's going to form a callus. Now, if you get a keratosis due to irritation, would that ever become malignant or pre-malignant?
No.
No. So that type of white lesion, still clinically, it's still called leukoplakia, still, right?
Yeah.
Leukoplakia is a clinical term, okay? So microscopically, it would be frictional keratosis or benign keratosis, all right? So frictional keratosis is one caused by irritation, okay? We'll talk about that later, all right? Or white lesions can be caused by exposure to carcinogenic chemicals like smoking, okay? Because there are so many hyperkeratotic epithelial lesions that present clinically as a white plaque, we have several descriptive terms. Okay, now we're talking about leukoplakia. See that there? Okay? And leukoplakia is defined as a white patch or plaque on the mucosa that cannot be rubbed off. Okay? Are you with me on your right spot? Okay. And cannot be characterized clinically as another disease. What do we mean by that? Well, another white lesion that we talked about last week is lichen planus. It's a white lesion, but it's clinically characteristic. We don't call a white lesion in lichen planus leukoplakia, because it is another. It's characterized as another clinical disease. Okay, this is important, number B. Leukoplakia is a descriptive term, not a diagnostic term. Okay, only a clinical term. It's a clinical diagnosis. I even hate to use the word diagnosis because it's not a diagnosis. It just tells you that it's a white lesion. All right. And here, number D, biopsy of these lesions to obtain a definitive diagnosis is mandatory. So the only way you can know for sure what a lesion is a
Biopsy.
biopsy. Okay? So that's why I'm saying when we looked at these quizzes, to me there's more than one answer. She's asking your top two. Well, your top two may not be the same as your top two.
Yes.
And your top two may not be the same as what she chooses. So how does she grade that?
Whatever she has it in her mind.
Well, but if you have something different in your mind and it's still reasonable, is that wrong?
Wrong. Yes. Wrong for sure.
No, it's not.
Yes, D.
No. Sada, come on. You don't know how to argue with a teacher enough, Sada.
Nah.
Whatever she wants, you wrote it down, you're gonna get a grade. If you write something else that was not in her mind, you don't get it.
Argue with her.
No. I
Yes.
don't. No.
I
That's the
did.
reason I failed.
I
At
argued
60
for-
something I failed because
She didn't argue with me because I was her boss.
Yeah.
You give in too easy, Sada.
Yes.
I didn't teach you guys to be nasty students, huh?
I'm not trying to
Argumentative students?
It doesn't work with these three charts.
Yeah.
Okay, number E, look at this, and we talked about this earlier, Brian. When biopsy, most clinical leukoplakia end up being what? Like you said, we talked about it. This is white lesion now.
No.
So most leukoplakias are benign keratosis, and that's what Heidi said.
Yeah.
Are epithelial dysplasias. Look at the difference. Most of them, 80% are white lesions. Epithelial dysplasia or squamous cell carcinoma. All right? At first biopsy, 20% of all idiopathic leukoplakias are pre-malignant or malignant. Okay? At first biopsy, 5% are outright malignant. So not a high percentage of those are malignant, but enough that you got to be careful. Okay? Speckled leukoplakia, only a clinical term again. Speckled leukoplakia is red and white. And when you come to speckled leukoplakia, do you worry more about speckled leukoplakia than leukoplakia?
Yes.
As far as being malignant?
Yeah.
Yes, you do. A much higher percentage of clinical speckled leukoplakias are pre-malignant or malignant than leukoplakia. And here it's, I don't know if she even says speckled leukoplakia has a greater risk of already being pre-cancer or early cancer than leukoplakia. Yes, you really worry about it. Okay, that lesion, Sada.
Yeah.
That lesion in the palate.
That was white and red.
That's
not,
right.
Yeah, that was not red. That was not white.
Right, that was speckled leukoplakia, more red than white.
Yes.
Okay, clinically it was speckled leukoplakia.
Yeah.
Okay, now, but speckled leukoplakia is only a clinical term. Okay,
Yeah.
microscopically, what could that lesion have been?
Epithelial dysplasia, Site2, no Site2, carcinoma.
Could have been carcinoma. Actually, it was a carcinoma in situ.
Okay.
It was.
It was.
Yes. Yes. Okay, but we'll come back and talk about it in a minute. Okay, now it's talking about speckled leukoplakia. Most of these can be epithelial dysplasia, carcinoma in situ, or early invasive squamous cell carcinoma. Right, okay, right. Red patch. Red patch is often due to inflammation. That's why when we were talking about red, we said if we have a red thing, most red things are inflammatory, what she's saying here, but if it has dysplasia, it's epithelial dysplasia, or carcinoma in situ, or squamous cell carcinoma.
Yeah.
Okay? So erythroplakia. Erythroplakia is just, again, a clinical term and not a descriptive term and not a diagnosis. It's not a diagnosis. Okay? It's a clinical diagnosis, but not a microscopic diagnosis.
Which one?
The erythroplakia.
Got it.
Okay?
Yes.
And as I said a few minutes ago, red patch often has a velvety surface. Red does. We'll even show some pictures of it. Erythroplakia may be mixed with leukoplakia, then it's called a speckled leukoplakia. All right? Number D, erythroplakia must distinguish must distinguish from lesions where red is due to inflammation, right? Okay. Now it says number F here, 60 to 90% of erythroplakia lesions are pre-malignant or outright malignant. 60 to 90%. Now, when you come to a white lesion, leukoplakias, what percent are pre-malignant or malignant? From the previous page before, don't look back, but give me approximate.
About which one?
A leukoplakia.
It's 80%. It's malignant. Oh, it's for the curve.
No, for leukoplakia.
Mm-hmm.
For leukoplakia.
What percent are pre-malignant or malignant? It's on the page.
80% was
No.
not the
20%.
20%?
20% of white lesions. But now this says red lesions, or erythroplakia, it says 80 to 90% are pre-malignant or malignant. All right, see the difference? So you worry more about a red lesion than you do a white lesion.
Yeah.
Okay, if it's not inflammatory.
Mm-hmm.
So white lesions, most leukoplakias are benign.
Yes.
80% are benign.
Yes.
But when it comes to erythroplakia, what percent can be benign? Maybe 20, 30%, or 10%.
Yeah.
Most are pre-malignant or malignant. And when we say pre-malignant, we mean dysplasia, right?
Mm-hmm.
All right. Papule. Okay, here. A pink or white papule develops because of proliferation of mucosal epithelium. Okay. Papules could be due to hyperplasia, dysplasia, benign, neoplastic, or malignant. It's just an elevated area. Papule's an elevated area. Can be benign or malignant, all right?
Yes.
So papule's just elevated.
Elevated.
Okay. So a squamous papilloma would be an example of a papule. An exophytic mass that is fixed and indurated should be presumed to be cancer unless proven otherwise, all right? If something's fixed or hard, real hard. Although like a fibroma is hard. We're going to talk about fibromas next week. They're hard, but they're all benign.
Mm-hmm.
Okay. Okay, squamous papilloma. Brian, what does a squamous papilloma look like?
Does it look like
Like a grapes.
Yeah, like a
Yeah.
grape.
Yeah.
Mm-hmm.
Or another term, cauliflower.
Yeah.
Yeah.
Cauliflower.
Looks like
It's
a
better.
cauliflower. Okay. Now, is a squamous papilloma a reactive lesion or a true neoplasm?
True neoplasm?
Yes. What is the difference between a reactive lesion and a true neoplasm?
I think a reactive lesion has to do with like a reaction.
Reaction to what?
To like something in the
Right,
environment.
due to irritation, some type of
Irritation.
irritation. Where a true neoplasm will grow on its own.
Yeah, so it's like a wart type
Yes,
of thing.
right.
Yeah. And
Well,
it kind of
right.
does look like a wart sometimes.
Well, it could,
Well,
but it can be
actually, yeah.
smooth and look like a fibroma too.
Yeah.
So a fibroma is a reactive lesion,
Mhm.
but a squamous papilloma is a true neoplasm. So these aren't uncommon. It says 1 out of every 250 adults can, or 3% of all oral lesions. So squamous papilloma is a fairly common lesion, okay? And it can be, and they're caused by what? They may be caused by human papillomavirus.
HPV.
Some of them are caused by that. Some are caused by irritation. They're not very. They are maybe caused by human papillomavirus, but they're low virulence and not highly infectious. Okay, they're exophytic, right? Exophytic means above the surface, and they're papillary. Okay. Now next page says cauliflower-like. Lesions may be pedunculated. What's the difference between pedunculated and sessile?
Excuse me.
Sadu. Do I have that right?
Sarah. Sarah.
Sada. Sada, not sadu.
No.
Sada.
It's R at the end. Okay. So what was the question?
What's the difference between a pedunculated lesion and a sessile lesion?
Goodness, I don't know.
Yes, you know.
Is
Brian.
this how like a solitary lesion or a mass.
Are most squamous papillomas sessile or pedunculated?
Does that
Sessile.
mean like inside of the mouth and outside of the mouth?
No.
What are
Never
the
mind.
sessile?
Pedunculated means it has a narrow stalk.
Okay.
Okay, so this would be okay. We got two lesions,
It's the
and
second
this is
one.
epithelium. This is squamous papilloma, papillary.
Yeah.
If it has a narrow stalk, that's pedunculated.
Oh.
If a lesion is elevated like this above the epithelium, but it has a broad base, it's sessile.
Okay.
So are most squamous papillomas pedunculated or sessile?
Sessile.
Pedunculated.
Pedunculated.
They can be sessile, but most are pedunculated. All right,
Okay.
and we'll look at pictures that will show that.
So can you get squamous papilloma outside of the mouth?
Yes,
Okay.
you can get them on the skin.
On the skin as well.
I thought that was only for vulgaris. For which one is it? Verruca vulgaris.
The various you can get on the skin
Yeah,
too.
the skin. Okay, so with both of them you can get.
Yeah, I
on the
think you can
skin?
get. I think you can have a squamous papilloma, a papilloma-like lesion on the skin.
Okay.
Now, don't hold me for sure on that, but I believe I'll look that up. But yeah, I think you can have a squamous papilloma. Yeah. Well, you sure can have one in the genital area, squamous papilloma. Yeah, you can have squamous papillomas.
Okay.
Yeah. So lesions are usually found often on the tongue or the lips and the palate. And it says here, uvula, often they're found on the uvula, okay? And what it is, remember, it's proliferation of epithelium. So a squamous papilloma is proliferation of this epithelium. It can have a connective tissue stalk to it, core, all right? But remember, it's proliferate. It is a. What is this whole lesions we're talking about? Epithelial lesions, right? So that's why squamous papilloma is in there. Okay. And the treatment for it to be what?
Excision?
Excision.
Yeah.
So let's look at let's go quickly through this.
What would a skin tag be? Would that be similar to?
A skin tag.
Yeah.
That can just be an elevated papule.
Oh, okay.
Yeah. I don't understand why this thing is jumping. Am I doing something wrong? Maybe I'm hitting the wrong button here. Could be this one, right? Reading view. I don't want the reading. Oh, here we go. Oh, now I got it. Okay. So look at this. This is connective tissue, right? Can you see this on there? Does my thing show? This is the basal cell layer. This is the spinous cell layer, and this is keratin on the top. Okay. And here is again keratin on the top. And this is keratin. This is called parakeratin because it still has some dead cells in it. See the cells here? That's called parakeratin. This is keratin. Both of these are going to be white. All right. Here's the basal cell layer. Okay. Acanthosis. I don't know if you had that term. Thickening of the spinous cell layer. Dysplasia means alteration in size, shape, and organization of cells. Verrucous hyperplasia means what? Finger-like projections. Okay. Atypia refers to abnormal cell features. So here's a question I asked you, Heidi, before.
Yeah.
What areas are keratinized and what areas non-keratinized? So we mentioned the keratinized, dorsal tongue, palate, lip, and gingiva.
Yeah.
Okay. And here, non-keratinized areas are more vulnerable to the development of malignancy or benign lesions, right?
Yeah.
So most of the malignant lesions are found in non-keratinized areas. Okay. But what confuse you is when you smoke, it can cause cancer, but it causes keratinization too.
Yeah.
So that can be confusing, right?
Yeah.
Does the term vulnerable, is that a term confusion to you, Sarah? Vulnerable?
That
You know what
means
that
we
means?
have a chance, more chance.
Yeah. Okay, you didn't guys never had leukodema? You had it earlier, right?
I actually don't.
Never had, I'm sure you did on normal things, but this, I put, but look, on the left-hand side here, that would be a leukoplakia. But leukodema is common, mainly in black people, or darker complected, and it's on the buccal mucosa like you see here, all right? But when you stretch it, the whiteness disappears. So that's leukodema. Somewhere you had to have this.
Yeah.
It sounds familiar.
Yeah, you should know this, leukodema.
Yeah,
The characteristic is you stretch it and it disappears. All right?
I remember that.
It's a normal type of thing, mainly in a dark complected person. All right?
So, is what causes the leukodema?
We don't know.
Oh.
It's just a spongiosis, or it's a variation of normal. Okay?
Oh.
And it disappears. No malignant transformation. So leukodema is something you don't worry about. You see it a lot in a dark complected. Some dark complected people, you'll see the buccal mucosa will just look white, but when you stretch it, the whiteness disappears. So you don't worry about leukoplakia. First you think it's leukoplakia, but it's not. So okay. And linea alba, you know what linea
Yes,
alba
linea
is?
alba.
Okay, that's where you bite it.
Yeah.
So that is a frictional keratosis,
Okay.
right?
Yeah.
That would be a frictional keratosis.
So would leukoedema be a frictional keratosis or no?
No, because it's not caused by irritation.
Okay.
It's just a normal. It's a normal thing. It's just. It has something to do with white space or spaces within the epithelium.
Okay.
Okay. Then okay. Now here's squamous papilloma. All right. Okay. So squamous papilloma. Here is, see, it's got a connective tissue core. This is the epithelium down here. Okay. This is pedunculated. Okay. And it's got some. So the squamous papilloma can be white or pink. So it can have keratin on the surface. If it's keratin on the surface, it's going to be white, but it can be pink. Now, Sarah, this looks like a squamous papilloma, right? It's papillary. Is that pedunculated or sessile?
It's pedunculated. This one looks like sessile, but you mentioned most of the time it's pedunculated.
Right, but this one looks what?
The other one, that it's.
What is the other one?
Sessile something.
Sessile.
Sessile.
Yes, you're right. That one's sessile.
Sessile.
You have a nice smile.
Thank you.
Okay, here's two more. Classic.
Peduncular.
Pedunculate.
Yeah, like.
Because it looks like a
One is
bush or
kind of
tree.
pinkish, the other is white. Where they found? Soft palate, lip. Okay, and just to let you know, those fingernails on the right hand side are not mine.
Has something on. Nail polish.
I don't know how you guys weren't wearing
Yeah,
gloves.
touch it. Wow.
We thought it was crazy to wear gloves.
Yeah.
Wow. That was not crazy. You get that stuff from someone?
You could.
Yes.
But these are not infectious. They're not very, this is not very infectious.
Oh, okay.
Here's two more. So, if she showed this on a picture, what's the diagnosis? I only have one diagnosis, squamous papilloma.
Papilloma.
But I'll show you a squamous cell carcinoma. I don't have it with me. They could look just like it.
And for midterm exam, we had lots of those questions.
Really?
We had to make a decision about it's site 2, it's benign, it's malignant, all of them.
That's hard.
So that would definitely not be Verruca vulgaris.
You know, here is a good question. When I gave an exam, I would not make you tell the difference between a verrucous vulgaris and a squamous papilloma. You can't.
Why can't you be
Because you only can tell microscopically.
Yeah.
But to me, this is not a verrucous vulgaris. I'll show you what a
So
verrucous
vulgaris
vulgaris
is
is.
like cauliflower too?
Yeah, verrucous vulgaris
Yeah.
goes like that.
Yeah, it's like longer.
Verrucous vulgaris is finger-like projections,
Mhm.
whereas squamous papilloma is cauliflower.
Mhm.
But you can't always tell the difference,
Okay.
all right?
Yeah.
And they're very closely related. They both could be caused by HPV,
Mhm.
Yeah, it's
but
both.
different HPVs.
Yeah.
Different.
There are about over 200 HPV viruses.
Yeah.
Wow.
Okay, reviewing now. Squamous papilloma, fairly common, certainly common in young kids. Cauliflower-like, usually pedunculated, just what we said, white or pink, and we said why.
Mhm.
It has keratin, okay? Any age, painless, tongue, lips, soft palate, okay? And etiology, HPV, in most of the lesions, may look like other lesions, could look like squamous cell carcinoma. We'll look at some squamous cell carcinomas that look like this, all right? Excisional biopsy, that's how you treat it. Now, verrucous vulgaris.
Vulgaris, yeah.
Let's go through the notes of verrucous vulgaris. Oh, she's stuck, wait a minute. She's stuck, I'm not sure why. Oh, here it is, it's next, I don't know, okay. Verrucous vulgaris is a common word, okay?
Question. If we promise we don't share that stuff, there is no way that we have those PowerPoints? Look at them, study them? No? Yes? Maybe you think about it. We promise no share. And then we
You
delete
promise
them.
that.
Yes, and then we delete it. We don't give it to someone else too.
Or
We just
what-
want to pass this course. I really want to pass
Okay.
it.
Yeah, I would do that if you gave me, I have no problem you looking at them. If
Okay.
you don't tell anybody,
I will not. We will not.
okay.
Heidi, you will not?
No,
Brian.
I won't. No.
No.
I promise I
Yeah,
won't.
I don't have a problem. Yeah,
Thank you.
I don't have a problem you looking at them. The only problem, now, here's what's gonna be funny. Most of these pictures are mine.
Yes. Yeah,
That you
I saw
saw.
your name there.
Well, even on
Yes.
that.
And your
So when you
fingers.
see her final, you're
It's
gonna
different.
see the pictures that are on the final. Could be,
Yeah.
right?
She doesn't have them, does she?
Yeah, she has all my slides. Yeah, what I'm gonna show you in a few minutes, her slides on this, and most of those pictures are mine. Yeah,
Oh, so this is your slide.
these are my slides.
Oh.
These
His
are mine.
PowerPoint is yours.
This PowerPoint is mine, not hers.
Yes.
I'll show you her PowerPoint in a few minutes.
Okay.
Your name was at the first.
I get confused on hers.
Mhm.
Here's where I get confused. Because she's talking about one thing and the other, trying to compare, which I don't have a problem doing that. But you gotta learn about the one and you gotta learn about the other one before you start comparing them. Does that make sense?
Yes.
Yeah.
I exactly
Because
compared
if
it
you
too.
start to compare things before you know all the things about this or know the things about that, you get confused about the two.
No, yeah, that's so true.
Yes.
But you should compare them,
No, yeah, at the end. And
yeah, to know the difference.
Mhm.
But learn the characteristic of one and learn the characteristic of the other, and then go back. So we're gonna look at her PowerPoint in a
Okay.
minute too.
Thank you.
Okay.
I have to transfer these. I have to transfer this to a
USB.
pen drive, I mean, to a thumb drive. If I transfer to one thumb drive, you guys could share it that way, right?
Yeah.
You can
Yeah.
transfer.
Do you
it.
I
have
have-
one?
I have
Yeah,
one.
I
You
have one of them. It has room on it too.
I,
Right.
yeah, I can get it. I'll get a thumb drive. I'll get one for you.
Okay.
I'll go to the store. and get one.
Thank you so
Oh,
much.
thank you.
Okay, so verrucous vulgaris, let's look at that. So again, young adults, children, it's caused by human papillomavirus subtypes 2, 4, 6, and 40. I don't think she's gonna ask you numbers like that, right?
I think
No.
maybe.
No.
but,
No, I don't memorize the numbers
Okay.
like that, okay? Now thing about verrucous vulgaris, they're more virulent than a squamous papilloma, so they're contagious.
Okay.
Wart is contagious, all right? So it's exophytic. This is exophytic, all right? And doesn't this look more finger-like? So
Yeah.
I wouldn't call this a squamous papilloma, would you?
No.
No.
I'd call it verrucous vulgaris.
Vulgaris, yeah.
And these often can be multiple, and when you look at the histology, here's the one characteristic of histology. All these fingers point to a central area. Notice that?
So
That's
it's
one
like,
of the, yes, yes, like that, right. Now here's a young kid up in the clinic, okay? And this was a girl, so she had them on her lip, okay? But she also did what? Sucked her finger all the time?
Oh.
So she transferred them to her thumb,
ooh,
or maybe she had them on her thumb and transferred them to her lip.
Mouth.
yeah.
Because you can auto transport them from one place to the other. And she also had them on her knee. Now sometimes verrucous vulgaris, as your notes say, can go away on their own. They will disappear. Some warts will disappear.
Yeah.
Or you can use medications for them. Remember, may spread to other parts of the body. May have a keratin horn, finger-like projections. Dysplasia oral warts, we're not talking about that. Condyloma acuminata, I don't think she talked about that, right? What that is, you guys should know. That is a venereal wart, all right? Still caused by human papillomavirus, and it's transferred by sexual contact. But from oral genital sex, it's you get it. So here's a guy who came into the clinic, and he had multiple, looks like squamous papillomas. You see those?
Mm-hmm.
See a big one here? Well, look at the one he had hanging out on his lip. Look at that.
Ooh.
Look at that. How would you like to have that?
Yeah.
So I said, well, what is this? I said, well, you got this from oral sex. Oh, I didn't have any oral sex. Well, I knew he was lying to me, because that's how he got it. See? Yeah. So normally these would be found in the genital area, but from oral genital sex, you can transfer it to the oral cavity. All right. So they're like a verrucous vulgaris, but they're caused by different of the HPV. They're just bigger and they last longer. But
What do you mean by venereal disease?
venereal?
Yeah.
Caused by sexual contact.
Oh, okay.
Yes. So it's one of the STDs, sexually transmitted disease. STD, sexually transmitted disease. Yeah. And then you guys didn't have X disease. You didn't have this one. You didn't have this one. So there's some on here you didn't have.
Here you go, look
Okay.
like you.
I don't know if I need to wipe those out for you or not. I have to see. Because you don't. I may just leave them on there, and then you would have to, you can just ignore that.
Okay.
And just look at the ones you want that correspond. Okay. So, leukoplakia. Let's talk about leukoplakia. We did talk about that. Frictional keratosis. Okay, so let's go. Remember, leukoplakia is a white patch on mucosa that won't wipe off, right?
Yeah.
And it's no other specific disease. Only a clinical term.
Yeah.
Okay? So, actually, the better term is never call it clinical diagnosis. It's a clinical term, right?
Yeah.
Because it's not a diagnosis.
Yeah. That's
Yeah.
why I get confused.
Yes,
You know?
right, okay? It's not a specific histopathic diagnosis. It is a pre-malignant lesion. So leukoplakia is a pre-malignant lesion.
Okay.
Okay? It's the most common oral pre-malignant lesion there is. So, different types. You can have frictional. You can have a frictional keratosis. This is what the types, okay? And we have that under E, all right? It can be related to smoking, smokeless tobacco, or idiopathic. In other words, some people have it that they're not smokers and there's no irritation. So let me ask you this question. Would you be more, let's say a person has a white patch on the side of the tongue, and it's not a frictional keratosis. Let's say you have two individuals, and when you looked at their lesions on the tongue, they were absolutely identical, okay?
Okay.
One's a smoker, one's not a smoker. Which patient would you worry about, the smoker or the non-smoker?
The non-smoker.
Why?
Because why would it like just appear? You know, if he
Why would
doesn't
it appear?
do,
Correct.
yeah, like
Correct.
you know, there has to be a reason. Why.
Right. I mean, I do worry about it in the smoker,
The smoker.
but I have a reason. So in the smoker, if you have leukoplakia, if that person quits smoking, the white lesion can disappear. In the what would I tell you to do? Well, there's
Yeah.
nothing you can undo,
Yeah.
so I would worry more. Does that make sense?
Yeah.
Okay, here we talked about, we did this already. So here's leukoplakia. Okay, now, if it's benign leukoplakia, what is the diagnosis, microscopic diagnosis?
Benign leukoplakia?
No.
No, wait.
Sometimes they'll use that term,
Yeah.
but you shouldn't.
Oh, you're asking if it's
Yeah, a microscopic diagnosis.
Oh, okay. Benign keratosis.
Benign keratosis.
Yeah.
So this is benign, or you could say benign hyperkeratosis.
Okay.
Some people, sometimes they use hyperkeratosis, sometimes they use keratosis. So
Yeah.
these here are benign hyperkeratosis, all right? So, this patient here, on your right, what does he do? What kind of habit does he have? If you-
Something, no? What the, yeah.
Smoking? Something
Smoking what?
Cigarettes?
Pipe? No.
Pipe. Why
Yeah.
pipe? And this is something you guys are supposed to learn today. It's in your notes.
Does that have to do with the heat?
Heat?
Or the contact to
But-
Because he has a
What do
terminal burn
you see all
too,
these little
no?
red spots?
Yeah.
Yeah.
Uh-huh.
So what's he smoke? Pipe.
Pipe.
This is probably a pipe smoker.
Yeah.
This is nicotine stomatitis.
Like this.
Okay.
Oh,
Now, this is leukoplakia, right? You don't know if that's benign or premalignant or malignant.
Yeah.
Most likely, just looking at it, it's probably benign, because there's no redness in it, okay?
But the redness on our right side is it just inflammation?
What these red areas are, is the opening to the minor salivary glands. So the heat and the smoke from pipe smoking cause irritation to the opening of these ducts to the minor salivary gland, and that's why you get these red dots.
Nice.
Okay, remember, leukoplakia is only a clinical term. 80% are smokers, so most leukoplakia is caused by smoking. Is there a lot of smoking in Iran?
Kind of.
Kind of
Yes.
regular cigarettes or,
Yes. Cigarette, and before, like my grandpa,
yeah?
they smoke something else. It's like a, I don't know how I explain. The Afghanistan made it, and we are close to each other. It's a farm, big farm, like a flower pot. They got it from that flower. Like my grandpa used it. That's
Huh.
for the medicine too.
Huh.
But these days, I think they don't have vapey things like here.
Don't
who
have
they,
what? Oh,
no,
okay.
they smoke
Smoke,
more
okay.
than that
Alright.
stuff.
Malignant transformation, okay, dysplasia is found 3 to 35% of cases. We talked about 20% of cases. You know, it all depends what report you read. But so leukoplakia, about 20% are pre-malignant or malignant, roughly, or somewhere in that region. Malignant transformation, 1 to 17%. I think in her notes she says 10%. All right. Okay, here's a couple of hyperkeratosis again. Right? This one was a non-smoker. That one was a smoker.
Oh,
Okay.
okay.
How you would want to differentiate that from what? Leukoedema,
Leukoedema,
Yes.
yeah.
right? But if you stretch this, it's not going to disappear.
Disappear.
In leukoedema, it's going to disappear. Okay, here, now, here it is on the lips. If it's in the wet area, it's going to be white. If it gets out here on the dry area of the lips, it won't be. It'll just be scaly. It won't be white. All right? So you can have scaly areas like here, but if it's in the moist area, it's going to be white. All right? So this would be a clinical leukoplakia. If it's on the lip, if it's like these areas, what is the term she asked you on the quiz?
Actinic.
Actinic
Actinic.
colitis.
Yes. colitis.
And actinic colitis, do you know from actinic colitis, is that a microscopic term?
Yeah. Oh, wait. Microscope.
Yeah, well, you better say wait,
That's,
wait.
no, it's not a term.
It's
It's,
clinical.
it's a diagnosis.
It's a clinical,
Clinical.
Yeah.
or a clinical term.
You see, I still
Right?
get confused. Yeah.
Because that can mean that could be benign or it could be malignant. We don't
Yeah.
know.
I have a question. Is there a difference between actinic keratosis and actinic colitis?
No.
The same thing?
Yeah.
Oh, okay.
Yeah. Colitis means the lip. Yeah.
Okay.
Sometimes they use the word actinic senile. Sometimes they'll use the word senile elastosis, and that's most degeneration of the connective tissue. You'll use that once in a while, that will show up too. Okay, here's hyperkeratosis on the tongue. Small area, like here, 2 areas here. Here's a larger area. Right? But you don't know if these are, now these are examples of benign hyperkeratosis.
Yeah.
Right? Here, now, here is something that's interesting. When you have them on the floor of the mouth, 45% of leukoplakias on the floor of the mouth have pre-malignant cells. So this is the highest risk area in the oral cavity for leukoplakia. So you would want to biopsy this area absolutely for sure.
Okay.
Whereas if you went back, but I'm not overly worried about that one. I would want to biopsy it.
Yeah.
But I'm not worried about that having a high percentage of dysplasia. But I am worried. Oh, wait. I am worried. Where'd the floor of the mouth one go? Oh, I am worried about that one. What's that one? Okay. Here's more, okay, on the lips we talked about those. Okay.
Would you be more concerned if it was at the floor of the mouth than if it was on the tongue?
Yes, I would, then a lot of board of the tongue. Tongue is still high, but I'm more worried about the floor of the mouth. The tongue, a lot of board of the tongue is 25% of white lesions, of leukoplakia. On the lip, of a white lesion on the lip, you got about 24% are pre-malignant. On the lateral border of the tongue is about 24% of pre-malignant. On the soft palate is about 24%, roughly. On the floor of the mouth, it's about 45%, nearly double. Does that make sense?
Mm-hmm.
So the highest risk area, for some reason, is the floor of the mouth. Yeah. White sponge nevus, you guys didn't do. Keratin, you didn't do these. X disease, you didn't do. We did that. Wait, am I going? Verrucous vulgaris, we talked about. Alright. Okay, I'm going back to this. Oh, okay. Okay, here's this shirt. This is good. So this was a guy I saw in a clinic upstairs. This is the soft palate.
Yeah.
Clinically, this would be a what?
Nicotine.
Leukoplakia.
Oh,
Okay.
Yeah, term.
Okay.
The term.
So what is, and he was a smoker. So this was caused by smoking.
Yeah.
So how do you treat it? Quit smoking would be one possibility. And check him in a couple weeks.
Yeah.
Or you would biopsy that day if he didn't want to quit smoking, right? So he quit smoking, some about a month later, nearly gone. So leukoplakia caused by smoking will disappear, which now I know this is benign. I know it's benign because it disappeared. If you have a leukoplakia caused by smoking and you quit smoking, often over a period of weeks, that leukoplakia will disappear. Now, if you had dysplasia, if that was a keratosis with dysplasia, and he quit smoking, will that disappear?
No.
Usually not. But if it's a mild dysplasia, because remember I said dysplasia can be mild, moderate, or severe? In a mild dysplasia, sometimes that can reverse itself. A moderate and severe probably will not. Now, here's another question. If you had a keratosis with moderate dysplasia, do they stay a moderate dysplasia? Or do they always progress to a carcinoma in situ, then a squamous cell carcinoma?
If it's moderate, I'm going to say it stays moderate.
No, it can stay, but it can't progress.
Oh, okay.
So any dysplasia can progress. I mean, so if something was if you did this and it was moderate dysplasia, and it never progressed, why would you want to, there's no reason to get rid of it. But dysplasias can always progress into a carcinoma in situ or a squamous cell carcinoma over a period of 18 months, 24 months, all right? So that's why we want to get rid of dysplasias, even though they're not outright malignant. A dysplasia is not outright, it's pre-malignant. Pre means it could form that. Does that make sense?
Mhm.
Otherwise, you wouldn't worry about it. If you had a dysplasia, well, okay, it's going to be a dysplasia for the rest of life. Who cares? But no, they can progress. Many of them will progress, but not all will progress. Just because you have dysplasia does not mean that it will
Disappear.
It will progress. Okay, so she had smoking in here somewhere too.
Yeah.
Okay.
Yes.
Well, okay, how are we doing? Oh, wow. Okay, actually, we're doing pretty good. If we can run 10 minutes, 15 minutes over, is that a problem?
No.
Since you don't have class?
You don't know.
Time goes so, we talk too much, I talk too much. Okay, specter of oral cancer, you wanna look at that part on the notes?
Okay.
Oral cancer accounts for 3% of all cancers, okay? 4% in men, 2% in women. Women have caught up to men now, about caught up, why?
Because they're smoking. They
More of
started
smoking,
smoking.
right. It's about 30,000 cases of oral cancer a year. Of all oral cancers, this is what you need to know too, of all oral cancers, 90 to 95% are squamous cell carcinomas. So you can't have cancer in the mouth that's not a squamous cell carcinoma.
Yeah.
You could have sarcomas, okay?
But that's like
5-year survival rate of oral cancer is around 50%. Actually, it's a little higher nowadays, okay? Around 50%. Okay? Let's turn the page. Contributing factors: tobacco, alcohol, betel nut use, actinic radiation, okay? Sanguinera, that's found in toothpaste, mouth sores. That will actually turn some areas white in the mouth. Microorganisms, candida can be mixed with it. Okay. Leukoplakia, okay, benign keratosis. We talked about benign keratosis, right?
yeah.
Keratosis with dysplasia, that's just a white lesion that has abnormal cells. So you're familiar with that, right? It can be mild, moderate, or severe, right? Then you have carcinoma in situ, right? Carcinoma in situ means all the cells from the basal cell layer up to the squamous cell shows dysplasia, right?
Yeah.
But it hasn't started to do what? Carcinoma in situ is a squamous cell carcinoma that's confined to the epithelium. Does that make sense? It hasn't invaded yet.
So it hasn't gone into the connective
It
tissue?
hasn't gone into connective tissue, right. Okay? Okay, now nicotine stomatitis. We've got to have that here somewhere. Okay, here's nicotine stomatitis. Okay, let's look at it. Okay, this is classic. If you showed me this picture, I would say nicotine stomatitis. All right?
Yeah.
People don't smoke pipes much anymore. They used to. When I was young, people smoked a lot of pipes. And I'm not sure why people don't smoke pipes. I think it's a big hassle, messing with the pipe, cleaning it, and things like that. But I'll have to admit, I've never smoked, except when I was 10 years old, snuck some cigarette from our grandfather. Everybody does that, right? Okay, you know. But if I had to take up smoking, which I never would, I would take up pipe smoking. It smells so, what a beautiful aroma the pipe smoking has. It does.
I think it like all has to do with like generations. Like I
Yes.
feel like your generation was like pipe smoking.
Right.
Ours right now is like, vaping,
Vaping,
and
right.
all
Yeah.
that
Right,
stuff.
right,
So
right. But pipe smoking was, I mean, it really, I can remember, and my grandfather, another grandfather, he rolled his own cigarettes. How, I mean, you never see people roll their own cigarettes so
Yeah.
much anymore.
Okay.
He had
My
a little
grandpa
pouch of
too.
tobacco and rolled his own. So, So this nicotine stomatitis has no malignant potential. And these red areas that you see here,
Yeah.
those are the openings to the minor salivary glands in the palate.
Ooh.
And so the red is inflammation of the orifice or the orifice means opening
Opening.
of
Yeah.
the duct. Okay, so there's no malignant potential, and it's usually due to pipe or cigar smoking. It can be due to actually cigarette smoking too, but mainly you would say pipe. So this is kind of an entity that's kind of disappeared. All right.
Is it painful or no?
No pain whatsoever. And here's another one on the right hand side. See that? If I showed you that picture, classic.
Yes.
Yeah.
Actinic cheilitis, here's actinic cheilitis again. Okay, we talked about that. All right. Here's keratosis with dysplasia. All right. And it just looks, it's benign leukoplakia, right?
Yeah.
Okay.
And here's the difference here. Okay, so this is normal epithelium with keratin on the surface. But all of a sudden it changes. Now this epithelium is thickened, and now you have some abnormal cells and a lot of keratin on the surface. So this is keratosis with dysplasia. Now, if it didn't have this keratosis on the surface, it would only be dysplasia. All right? And here too, normal epithelium, okay, low keratin up here, and now dysplasia. Look at the difference between these cells than these cells right here. Now these cells are starting to just about want to invade. So that's severe dysplasia. A lot of mitosis and things like that.
And that's pre-malignant.
Yes.
Okay.
Right. So here's keratosis with dysplasia. This one's hard to see. Just a small area right here. All right? Here's more. Keratosis with dysplasia. Clinically, it's actinic cheilitis. Here's a couple of them. Look at these. Now, in a case like this, you'd have to biopsy more than one area. All right?
So to know that it's keratosis with dysplasia, there has to be a biopsy?
Yes. Has to be a biopsy. There's no way you're gonna. I mean,
What is the diagnosis for something like this?
Where's
It's
the
all
what?
white. It's diagnosis for that. If we see
Clinical diagnosis?
Yes,
What's the clinical diagnosis?
it's loco. It's a white
Leukoplakia.
patch and it doesn't come
It's
up.
leukoplakia, right?
Yes.
So if you biopsied several areas in this case, what could be the microscopic diagnosis?
It's hyperkeratosis.
Okay,
or
benign keratosis.
Benign, yes.
Okay, what else?
And then cell carcinoma. No.
And what?
Carcinoma. Squamous cell carcinoma.
Okay, that's,
And
okay, so you're telling the benign one, you're telling malignant, what's in between?
Dysplasia.
Keratosis with dysplasia,
Yeah,
because it's got keratosis on it,
and carcinoma inside too.
right, you got them all.
Okay.
Does that
Got
make
it.
sense?
Yes. Thank you.
And when I asked the test question, every time I took a test question, that question was always on my test. You had 4 fill-ins. Show a white lesion like this, if you biopsy, give me 4 microscopic diagnosis.
Clinical cell.
It would be benign
Yeah.
keratosis, keratosis with dysplasia, carcinoma, say 2 squamous cell carcinoma. Does
Carcinoma.
that make sense?
Yes. Thank you.
I don't know if she ever asked you that. Peripheral lupus, I don't think you guys have that.
No.
Okay. Let's go back to snuff dippers, and then I'll go show you hers, and the other things we'll do tomorrow, okay? Then we'll go over the quiz. There's not much on the pipe, okay. Here's smokeless tobacco.
Yes. Smokeless.
So smokeless tobacco, very characteristic. A lot of kids use smokeless tobacco, and if you hold it in the same area, you'll get a very typical patch. And you hold it in the vestibule,
Yeah.
and then you spit a lot. But if somebody, and it does have it can be a pre-malignant lesion. Not really, actually, smokeless tobacco is not high in pre-malignancy. Takes many years to turn into a malignancy. If you quit smoking in about 6 months, that will disappear. Now, not all smokeless tobaccos do you have to spit with. There is one that's out popular in the last few years, a smokeless tobacco that you don't have to spit with. Do you know what that is? Snus. You ever heard of the word snus? Next time you look at when you go on a 7-Eleven or when you get gas, okay? And if you look where all the smokeless, where all the tobacco is, you'll see a little it will say snus, okay? Snus is something that was started in Scandinavia years ago, but it's a smokeless tobacco in little tiny pouches. They're pouches, okay? And you don't have to spit with it. So why would they came out that with now, okay, is that you can use smokeless tobacco on an airplane. You don't have to, you can still have your nicotine rush without having, without doing that. So you'll see snus. Most people, and now it's in the United States. But now, I went into a place the other day and I bought a soft drink. Although I don't drink soft drinks very often, but I've been addicted to them years ago. And you just get that urge once in a while. You knew you shouldn't do it, but you do it. Okay. So he had tobacco there, and I asked him, oh, snus. I asked him, how many people buy snus? I'm just curious. Not a lot. Now, when I gave a lecture to dentists, and I asked them about snus, I could have 100 people, maybe 2 or 3 people raise their hand, know what snus is, which is interesting. But he also said most people buy SWAT, S-W-A. I'm gonna have to go back. And
Is that the energy drink? The small one? No?
It looks like smokeless tobacco.
Oh, no.
What it is nicotine, but it's not tobacco. I have to find out what that is. I looked it up on the thing. It comes from tobacco plant, but it doesn't have tobacco products in it. I don't know how you could do that. But again, you get the nicotine rush. I mean, that's what you're addicted to, is the nicotine. You know, nicotine is one of the highest addictive drugs there is.
Oh.
Yeah.
It's one of the most addictive drugs you can find. All right?
Wow.
But nicotine by itself is not harmful to you. We think of nicotine being bad. I'm not saying it's good, but it's not really the harmful part. It's the carcinogens in the tobacco that are harmful because the problem, cancer. Yeah. All right, let's go back now. Oh, here's more smokeless on a young kid. I made him try to get him to quit. So see on the right hand side, see how it started to go away.
Yeah.
Takes a while to go away.
Is it possible to extract nicotine from the tobacco and sell just the nicotine?
Yeah, I think you could. I don't know how. Well, isn't that what vaping is?
Oh,
That's what vaping is.
I see.
Yeah.
Okay.
And then you mix it with the other thing. Yeah.
Yeah.
Beetle quid. Are you familiar with beetle quids?
It's like plant
It's a pan.
or
Called a
leaf.
pan.
Oh,
So what they do is they put tobacco in a beetle leaf, and they use this in India and places like that.
Yeah.
They wrap it up and they chew this beetle quid. This thing, they chew on this thing after they eat. They may do that in Iran too. You may have beetle quids. I
I
don't
have
know.
no idea.
And then you get addicted to it. After you have a dinner, you all sit and here's beetle quids in the middle and each chews on it. Very addictive. Very addictive.
Oh, we don't have this option.
You don't have that?
No.
Okay.
After dinner.
Okay, and then here is, it actually causes a beetle nut. You know what a beetle nut is? Here's a beetle nut. People from Asia choose beetle nuts, and it causes oral cancer.
No.
So oral cancer in the United States is 3%. Oral cancer in India, of all cancers, is 40%.
What?
40,
That's crazy.
because they chew these beetle nuts. So I took a beetle nut,
Is it a nut or?
yes, a nut.
They made it like that or?
No, I put
it's-
it on a lathe and made a vase out of it.
Oh,
This is a vase.
yeah, yeah.
It's only that high.
Oh, got it.
And I used dental instruments to carve the inside of it
Oh.
while it's turning. And then it had one little imperfection right here on the rim. So I used dental composite and filled it in.
Artistic.
It's like a nut, like cashew, walnut.
Yeah, it's a nut.
Is it yummy?
I've never tasted one. It's addictive. I don't think it's yummy. All right, let's go show her stuff. Let's see. Let's show her stuff, and then I will. Then we'll be through. Oh, yeah. Oh, we're gonna go over the test. Okay, here's her stuff. All right.
It's just kind of interesting that because those beetle nuts they just form in nature, right?
Yeah, they grow on trees.
They grow on trees.
Yes.
But they cause cancer.
Yes.
Usually, I think of like something that's made in a like manufactured that.
Oh, cancer. No,
Yeah.
that's a natural thing.
Yeah.
That's crazy.
Okay, here's her outline. Let's go through that. All epithelial lesions arise from pathognomic changes of the oral mucosa. Okay, here's the picture of epithelium again, right? Is this keratinized or not keratinized?
Yes.
Yes.
The
Thick keratin.
layer.
Yeah. Causes of lesion rise in the epithelium or from basal epithelial cells. Developmental anomalies. If it's a developmental anomaly called hamartoma, we're not going to get into that. Response to local factors can be physical, like chewing on an area, or chemical, like tobacco. Transformations by carcinogens, like smoking, or infections, like HPV, like squamous papilloma, right?
Yeah.
Okay, so here's the etiology. Physical or chemical ones are frictional keratosis, benign keratosis, actinic cheilitis, nicotine stomatitis, smoker's tobacco keratosis. We looked at those, right? And those are physical or chemical, okay? Transformation to carcinogens then would be the keratosis with dysplasia, smoker's tobacco keratosis. That doesn't also, smoker's tobacco keratosis doesn't always show dysplasia. Most of the time it doesn't. Carcinoma situ, squamous cell, verrucous carcinoma. Those that are caused by HPV or squamous papilloma and verrucous vulgaris. Okay. Epithelial lesions can be flat or elevated, right? Can be smooth, rough, papillary, right? Papillary, squamous papilloma. Well defined or diffuse. We looked at both those. We saw some diffused for the whole mouth. We saw some were well defined. Can be white or pink. It's white, it's got keratin on it. Can be ulcerated or indurated. But we haven't looked at the ulcerated ones. We will do that when we get squamous carcinoma. Okay? Lesions that have mass. Okay? Here's two of them. What's the one on the left-hand side? What's the one on the right-hand side?
Squamous papilloma.
Squamous papilloma.
And verrucous
Verrucous vulgaris.
vulgaris.
Squamous papilloma. Verrucous vulgaris. Okay. Here are the characteristics of it. Now we can compare the two, right?
Yeah.
Makes sense. Okay? So they're both common. They're caused by different strains, right?
Yes.
Any age. Verrucous is often young people, and okay. Any site, basically any size possible. They're both painless, right?
Yeah.
One's cauliflower-like, but longer projections, so more verrucous-like, right?
Yeah.
Okay? But treat them both the same. So now we can compare them, that makes sense. Okay? What would we call both of these?
Squamous papilloma.
Yeah.
Well, the left one could be either one. The right one definitely is verrucous vulgaris, the right one, right? What she put to the left, verrucous vulgaris, because it's flat. But if I need a closer up picture, this one for sure is verrucous vulgaris.
Okay.
Sometimes you can have multiple verrucous vulgaris in the mouth. We looked at these. This is a squamous papilloma. Sarah,
Yep.
papillary or sessile for the left one?
Left one is sessile.
Yes.
But that one,
This one, this is,
it's
okay,
not
this is squamous papilloma.
papilloma.
This is verrucous carcinoma, we'll get that tomorrow. Okay. This is verrucous carcinoma. What's the one on the right-hand side?
Vulgaris.
Verrucous vulgaris. This we will get tomorrow. Squamous cell we will get tomorrow. I should charge her.
Yeah,
I should
these
check.
pictures, we had them
I should
before.
charge her for using my pictures. I should charge her a fee.
Yes.
You should.
Yeah, I
I
should
think
get a-
you should charge the school.
I should get a royalty, huh?
Yes. Yes.
Okay.
Okay, here's one on the, what's the one on the left?
Nicotine stomatitis.
Okay, the one on the right, we haven't talked about that one. This one is this, what's the one on the right?
Nicotine.
Nicodemus.
Yep, no,
No.
yeah, it is.
really.
Actually, no, this was, this is a little bit of nicotine stomatitis also, but with the pipe. Verrucous keratosis? No, it's not verrucous keratosis. That's wrong. Ignore it, it's not. Okay, here's, the one on the left is what?
Benign.
Yeah, it's keratosis with dysplasia.
Dysplasia.
But we don't know it's dysplasia.
Okay.
Could be benign keratosis. We don't know. The one on the right, frictional keratosis. We don't know that. Frictional keratosis could be. The one on the right, I know was my patient. She was my regular dental patient. She was a lady who worked in the veterans, and she was a heavy smoker. This is a keratosis with dysplasia. She wouldn't quit smoking. I said, hey, you need to quit smoking. She said, you know what? I'm not going to quit smoking. I enjoy it. She was kind of a nice lady. I said, you know what? You're too fat. You need to lose some weight, too. She told me. Well, we had a good relation back and forth. Okay, the one on the left could be what?
Because it's
Caused by a denture.
Oh,
Friction.
so
It could be a frictional keratosis,
yeah.
or it could be a benign keratosis. Either one. How about the one on the right?
It can be anything, honestly. It can be benign.
It could be benign, but I know it's floor of the mouth. I get worried about it. So what would you think? What would be your first choice?
So if it's floor of the mouth, it'd be squamous. Squamous.
Could be. There's no
Squamous
redness
cell
here.
carcinoma.
If you're gonna have squamous cell, usually you're gonna have redness.
Okay.
So most likely this would be what?
Floor of the mouth. Floor of the mouth.
What would be
I
the
know you just
microscopic denial? Clinically, it's leukoplakia.
Yeah.
Yeah.
Of those four things that we said, what?
Carcinoma in situ.
Could be.
Or benign character. No. I said that already. What's the other one?
Other ones what?
Not benign keratosis, but dysplasia.
Yes, keratosis with
Keratosis.
dysplasia. I bet that's what's gonna come up. I haven't
Yeah.
looked at this. Keratosis with dysplasia, because floor of the mouth. Okay? Okay, the one on the left?
Smokeless.
Smokeless tobacco.
Yeah.
Okay?
So is that usually in the vestibule?
Usually the best, that's where you hold smoke it. The one on the right, heavy smoker?
If it's heavy smoker,
Yeah.
it would still be smokeless tobacco.
Uh,
Or leukoedema.
It could be
No.
leukoedema, but when you
Leukoedema.
stretch it, it doesn't disappear.
So then it'd be smokeless tobacco.
Smokeless tobacco. Keratosis.
No, but his whole mouth was this way. It's
Even
not
the
in the
palate?
vestibule,
Oh,
so it's not smokeless tobacco.
it's
And
not
they can't-
leukoedema too?
Could be benign keratosis, could be keratosis with dysplasia.
Oh,
right?
Okay.
I think she's gonna say benign keratosis.
Okay.
And I remember the kid taking the picture. His whole mouth was that way.
But it wouldn't be nicotine stomatitis because it's not.
No.
Okay.
Right, right.
Okay.
Because it's on the buccal mucosa.
Okay.
Yeah. Nicotine stomatitis is only in the palate from the cigar.
Okay.
Okay, this is a good one.
Okay.
On the left-hand side, what do you think on this one? Clinically, it's a leukoplakia.
Yeah.
Mm-hmm.
Probably looks like it's caused by what?
Irritation. No.
Yeah, could be. Irritation due to what?
Maybe
Uh,
the tooth denture. No, not denture.
No denture.
Brushing.
Brushing.
Yeah.
If it was caused by brushing, it'd be frictional keratosis.
Yeah.
But let's say it's not. So that would be, that looks benign, right?
Yeah.
Okay? How about the one on the right?
It's leukoplakia, but I would say that it's keratosis.
Out of those four, what would be your choice?
Benign keratosis.
Okay. Benign, on the right-hand side, benign keratosis, that'd be your first choice?
Oh, on the right side?
Yeah, on the right side.
I would say benign keratosis or
Okay. How about the one on the left?
friction keratosis.
Do what?
Friction?
Could be, yes.
Okay. Due to hard
Frictional
brushing.
keratosis?
Yeah, friction keratosis.
Okay.
Or, okay, so friction
Maybe they're both.
keratosis.
Frictional keratosis.
Could both be frictional keratosis? Yeah, how on the gum tissue there? Yeah, could be. Okay. Do you worry about the one on the left being dysplasia at all? If I said benign, if I said you're standing up, and I said decide if this is benign keratosis or keratosis with dysplasia, you would stand up for which one?
I would say benign.
Okay. You, Sarah.
Benign.
Yeah, me too.
Okay. You all would have to sit down.
Wow.
Dysplasia.
See what I'm saying? You don't know, do you?
Yeah.
You only knew. I thought this was benign.
She knows.
No, I know. I just my patient.
Oh.
She knows.
So, but the only way you could see that is with the biopsy.
Yes. Okay, the one on the right.
Mm-hmm.
So if we make a good educated guess, you think you'll?
That's what a differential diagnosis is.
Okay.
Right. So why don't you think of those four?
Okay.
Because you don't know without a biopsy. You can have some of an idea. When you go back and see this floor of the mouth one.
That one is probably more.
This
like,
one here. This one here. That one, I'm not.
Yeah.
To me, I'd lean more towards keratosis with dysplasia than I would benign keratosis. Does that make sense?
Yeah.
This one, probably caused by a partial, this rubbing,
Yeah.
I would say benign keratosis. Does that make sense?
Yeah.
And what were they? Well, and you saw the diagnosis there. Okay. Now let's go to, okay. Okay, here's two of them. The one on the left, what?
Benign keratosis.
Yeah. What's interesting on this patient, she was a commercial bird whistler.
Bird.
A bird whistler.
Okay.
She made records of all the birds whistling.
Oh.
Wow, that's cool.
Non-smoker. You think like your friend in them up there could, by whistling all day, could cause that? I don't know.
Like she'd whistle like a bird.
Yes.
Yeah.
Yeah.
Different kind of birds.
Yes, different birds. I mean, could that cause it?
Just whistle.
Would you biopsy that?
Yeah.
Yes.
Yeah. Do I worry about it?
Yeah.
It's not a high risk.
It's not a high, That's
No.
not a high risk one to me.
But like.
So what's the one on the right hand side?
Nicotine stimulator.
Yeah. And why that one area? What hits that right there? Get out of here.
The pipe.
Yeah, pipe.
Hi.
Okay, look at the diagnosis. Benign keratosis. Benign
Benign.
keratosis.
Oh,
They're
Yeah.
both benign.
Benign
because
keratosis.
nicotine stomatitis is
Oh,
pretty
yeah.
much benign.
Yeah, it still is. It is still nicotine stomatitis. It's both.
Okay.
It's both. Either one would answer. And this is,
Dysplasia.
okay, we'll finish that. Is somebody going to use this room right now? Is that why you want to ask them if they're waiting to get in
Yes.
this room? Ask them, and then we'll get out.
So if you were to be anything other than a pathologist, what would you have been?
Orthodontist.
Oh, so you would have been in the dental field.
Yeah,
Okay.
yeah. So I am in a dental field. I am a dentist.
Oh, right, right. But if
I
you're
took dentistry first,
yeah,
and then practiced.
He said no.
No? He said no?
He said
Oh,
no.
okay, we'll go back and look at this. Yeah. So let's go back, now I wanna go back to, okay, so this is where we were, so let's go to the next one. So on the left-hand side, clinically, both of these are what? Leukoplakia.
Uh-huh.
Do you worry about it, either one? What would be your diagnosis? What would be your first diagnosis?
For that one, for that one.
Either one.
Benign keratosis. Just because it's like the highest one for leukoplakia.
Could be, but it's on the side of the tongue. Does thickness have anything to do with it?
I don't think so. Or the thickness of the lesion?
Yeah, it's not necessarily. I would worry could either be dysplasia in either one of these, because it's a non-keratinized tissue. And I think, keratose dysplasia. But here, people may have gone the other way, because this one is thicker. They may say that's keratose with dysplasia. This one may have been benign keratosis. All right.
What is the other one that it's not that much thick? It's keratosis.
The thicker one?
No, not the thicker one.
But we don't know on these. We only know because of the biopsy. I'm not showing you these and think you're going to get it right.
Yeah.
Right?
Yeah.
I'm telling you, hey, it could be one of these,
It can be
and you're just looking at the possibilities, but you don't know for sure, right? But we did learn when we saw the floor of the mouth went back there a ways, that we worry about. Okay. Now, here's a good one. The left-hand side.
Floor of the mouth.
Dysplasia.
Yeah.
What would you choose for this one?
Dysplasia.
Benign
Keratosis.
keratosis.
You say benign keratosis, you say keratosis with dysplasia.
Yeah.
What does Brian say?
The left one would be keratosis with dysplasia.
Okay. What is the right one?
Smokeless tobacco.
Smokeless tobacco.
Yeah,
Keratosis.
smokeless tobacco.
Yeah.
Because it's right where they hold it. Okay. So you're saying benign keratosis?
Benign, yeah.
I would choose her over you.
Dysplasia.
Because why?
It's floor.
Yes. Okay, so let's look. And I know what this was. I picked both these. It's not. I don't think this was. I think this was a dysplasia. Okay. I may have this slide label line. But let me ask you this question. What % chance could this been dysplasia?
Oh, because it's on the floor of the mouth?
Right.
It has a higher percentage.
Right,
for
what
sure.
percent?
That was 90 or 80. No. 40 is
20?
45.
45, yeah.
What % chance the one on the right being a dysplasia? High or low? Smokeless tobacco. Low.
I feel, yeah.
Smokeless tobaccos do not show a lot of dysplasia. They don't. In fact, they did a study. They checked 1,000 ball players, and of all who used smokeless tobacco, or they took the ones that used the smokeless tobacco, and all the ones that had a white lesion, they biopsied them. I forget how many it was, and there was only a small number that showed dysplasia. But what happens after 20 years, 30 years? These areas may turn into a malignancy. So this is keratosis, smokeless tobacco keratosis. Okay. How can you tell them apart? Is leukoplakia benign or dysplastic? What?
Both? Or it could be both?
Could be both.
Both, yeah.
Yeah.
Is speckled leukoplakia benign, dysplastic, or already carcinoma?
It could be.
It's not benign, I don't think. But
That's a good question. That's really a good question. What do you say?
We don't do biopsy to figure it out?
Well, you would do a biopsy to figure it out, but is a speckled leukoplakia benign, dysplastic, or already carcinoma?
It's already carcinoma.
Yeah, I would say. Yeah, I'd say what Sarah said because it's like speckled.
But speckled leukoplakia,
Yeah.
remember from your notes?
It's in the middle.
60 to
Yeah.
90% are dysplasia or outright carcinomas. Where's this regular, the left 10 or 20% are benign.
Benign, yeah.
So it can be benign.
Okay.
Most of them are premalignant or malignant, but they could be benign. All right? You were thinking most of them are malignant,
Yeah.
but you're saying they're all malignant. Close to all are being malignant,
Okay.
right? How can you tell?
Biopsy.
That's right. That's why persistent lesions must be biopsied, right? Lesions without an obvious mass, red lesions, erythroplakia. right? These are, the one on the right-hand side, clinically you would call a what?
On the right side.
Huh?
On the that one would be like clinically.
Yeah.
Would be leukoplakia. No.
No, it's not leuko.
No. 'Cause
It's
The one on the right.
oh right,
Oh
it's
right.
leuko.
Sorry,
Oh,
leukoplakia.
It's squamous cell carcinoma.
Clinically, you, as a clinical term to describe it, you would call it what?
Leuko, it's a leukoplakia patch
But
for
it
the
seems some
denture.
There's redness there too.
Yeah.
Oh.
That's speckled leukoplakia. Most speckled leukoplakias are dysplasia or carcinomas.
Yeah.
Not all. That's the question we just had. Not all.
No.
Could be benign.
Yeah.
But a high percentage, I would worry about that lesion. I would really, floor of the mouth, speckled. To me, I'm thinking dysplasia or outright malignant, okay?
Yeah.
On the left-hand side, this lady never smoked. Her name was Mrs. Cash. Right here, can you look at that? It's kind of hard to see.
Yeah.
There's a little bit of redness.
Yeah.
It's speckled.
Speckled.
What do you think the diagnosis was on her?
Carcinoma inside too.
It was carcinoma in situ. Never smoked. But because of this little round area right there,
Yeah.
okay, let's see if she got the diagnosis right. Yeah, it was carcinoma in situ. This one, oh, she didn't say on the other one.
Maybe they're both carcinoma.
Yeah, they'd both be. Okay.
Both of them carcinoma.
How about this one? This is back on the retromolar pad on the left-hand side. What would you think on that?
Carcinoma in situ.
Or squamous cell carcinoma, carcinoma in situ, I really think of. How about the right side? That's soft palate back there.
Oh yeah, that would be same carcinoma in
Squamous.
situ or squamous cell carcinoma.
Which one of the two? Why? Sarah,
Both of them squamous cell carcinoma.
Yeah.
both squamous cell?
Yeah.
Squamous cell
Both of them.
carcinoma. Or yeah.
Yeah, to me, I would think both of them are squamous cell carcinoma.
Yeah. They were.
I mean, especially the one on the right-hand side.
Yes.
That's a nasty looking lesion,
Mm-hmm.
right? It's ulcerated.
Mm-hmm.
And you look at that, you know it's malignant, okay? That's good. Here is,
That's the tricky one.
here, does the one on the left-hand side look familiar to you?
Yeah, that was for quiz today.
That was the quiz today.
Yes.
This is with her denture in. You saw with her denture out.
Oh.
Oh, I see. What you mean?
So that looks speckled.
So that's kind of a speckled
Yeah,
clinically.
it's a speckle.
But
What do you think the
it's
diagnosis was?
for sure?
Carcinoma in situ or squamous cell.
Okay.
Yeah.
All right.
That's what I said.
All right. How about the right-hand side? This was a faculty member's mother who never smoked, never used any alcohol. And it was a lesion they thought was a denture sore, and they ended up keep adjusting the denture, and never did go away. What do you think on that one?
Carcinoma in situ.
Yeah, why do you think that?
Because on the previous one, you said that the lady didn't smoke.
All right. Would you worry about that lesion if it was persistent?
Yes.
Yeah.
Okay, let's look. Okay, here's the answer to your quiz. Carcinoma in situ today.
Inside too.
Okay, here's this one. Never smoked. It's the same for both. Both of them are carcinoma in situ.
Just a quick question. For the one on the picture on the right, is that at the vestibule?
Yes, in the vestibule. She wears a
Okay.
denture. You see the ridge. This
Okay.
is the ridge. The
Okay.
denture ridge, no teeth.
Okay. Is that? But that isn't like a high risk site, is it?
Not a high risk area.
Not a high
No.
risk area.
No, that was really unusual.
Okay.
I didn't suspect. I was
When
I
you
thought
pick
that was
inside
possible,
too.
but
When it's
an older
inside
lady
too.
who never
When?
smoked.
Oh.
Yeah.
When it's like red.
Between?
Yeah, like red and speckled, right? Carcinoma in situ is usually speckled.
When we choose
or
inside
Carcinoma in
too.
situ can be white, it can be speckled, it can be outright red. It can be
Okay.
neon.
How I should know it's inside too, it's not the others.
Carcinoma in situ means means that all the cells within the epithelial layer, within the epithelium, show dysplasia. It
Okay.
hasn't started to invade yet.
Okay. It's before the malignancy. It's before the squamous cell
Yes,
carcinoma.
right.
Okay.
Soon as these cells start to invade the connective tissue, then it's invasive squamous cell carcinoma.
Carcinoma. Okay.
So squamous cell carcinoma shows invasion. Carcinoma in situ is a malignancy that hasn't invaded yet.
Got it. But it's more than the dysplasia.
It is dysplasia, but it's dysplasia through
More
severe
part.
dysplasia.
Okay.
Okay, we'll get these tomorrow. We'll go through these tomorrow when we go through it. All right, let's go through your quiz.
Okay.
Then we'll quit. No, do you guys dream oral path at night?
I get nightmares.
What?
So on November 8th, we have exam from general path,
Oh,
like general, like injury, inflammation,
Yes.
not that stuff.
no.
Yeah, not oral path stuff. Okay,
Should you start reading? Did you study for them?
I started, yeah.
You started?
Yeah.
Awesome.
okay, what do you, look at your answers, don't change your answers, but what do you,
Okay.
what'd you put here?
I put carcinoma in situ.
Uh-huh.
And that, actually, that's the first one I put, carcinoma,
Yeah.
because I knew the patient,
Yeah.
okay?
And
What else did you put?
Squamous cell.
squamous cell carcinoma.
Could be, okay.
Wrong.
What else? My second answer,
It's not a speculation.
I put my third answer was squamous cell carcinoma. My second answer was, what do you think? Keratosis with dysplasia, number G.
Keratosis with dysplasia. Oh, yes, yes.
Yes. So I put D, carcinoma in situ.
Mm-hmm.
I put G, which is keratosis with dysplasia. I put L, squamous cell carcinoma.
Mm-hmm.
Okay. For 1 or 2. I also put C with the question mark behind it.
Yeah.
It could be a benign keratosis.
But it's not
But a small
white.
percentage.
No, it is.
It's not real white, so that's why I put a question mark. But it could be. There is some whiteness there. I also put E. That's red lesion in a way. It has to be erythroplakia. The better one would have been speckled leukoplakia, K, which I put.
Yeah, I chose that one. It's
Yeah.
like because I thought it's
Right,
white and
Right. So I would so if I was grading that, I'd have to give you the right answer to that, because she's saying, what are the 2 best diagnoses for the top of your differential diagnosis? Well, did she need microscopic, or is
No,
she
no.
talking about clinical?
clinical. The microscopy one, she never asked about
Well,
them.
but
From us, from dental
But-
school, dental student, she asked.
yes, but when she says diagnosis, you can only make a diagnosis if it's microscopic. So that's why I'm not sure what you want. So I would be very liberal here.
I have a question about so because I know that if you said like speckled leukoplakia, that's a clinical term.
That's only a clinical term.
Okay, but
That
So-
would be my clinical term to describe it.
okay, but that wouldn't be a diagnosis.
There wouldn't be a diagnosis.
Okay,
It would be a clinical diagnosis.
a clinical diagnosis.
Right. And I'm not sure I like the word diagnosis behind clinical. It's a clinical term or a clinical diagnosis.
Okay.
But it's a term that describes the lesion. It clinically describes the lesion.
Okay.
So if you were clinically describing it, you would use speckled leukoplakia. Or it's mostly red, I would call that erythroplakia too. I don't have a problem with erythroplakia. Because when I saw it, I call it erythroplakia. Okay? That's why I'm saying, to me, there's more than one answer on this. But I'm not sure what she means by 2 best diagnoses. When she says 2 best diagnoses, is she talking about clinical terms, or is she talking about what the biopsy would be, microscopic term?
Biopsy.
Yeah, she probably talked about the biopsy,
Yeah.
I think. I don't know.
Okay.
Okay, this one,
Actinic.
Actinic.
Actinic
I don't think
keratosis.
I'd have a problem with that.
Mhm.
I put A, okay?
Yeah.
This one, I have no problem with.
Basal cell carcinoma.
No,
No.
squamous.
No, not
cell
basal
carcinoma.
cell.
Squamous.
Outright
Squamous.
squamous cell.
Yeah.
It's a
No
yucky
problem.
one.
I
No
would-
problem with that
Yeah.
one.
Squamous
5.
cell.
What are 2 best diagnoses for the top of your differential?
Keratosis with dysplasia.
Keratosis with dysplasia would definitely be 1.
Benign keratosis.
Actually, the first one I put was benign keratosis.
Okay.
It
And
doesn't
then the
matter
next one I
which
put
one
was
is first.
keratosis with dysplasia, which was G.
Yeah, that's what.
The next one I put was carcinoma in situ. I can't
Yeah.
argue that one.
Yeah.
And I actually put H, which is clinical term leukoplakia. I put F, which would be frictional keratosis. So
Yeah.
I don't like those last 2, but I can't argue it.
So it doesn't matter which one is first, which one is second, or
No.
No, okay.
Oh, yes, it does.
Oh, really?
Hmm.
Because for
Sarah,
5,
don't believe me.
because for 5 I put G. So I thought the first one is keratosis.
5 is G, that's fine. What did you put for 6?
C.
Huh?
Yeah.
C. Benign
Yeah,
keratosis.
good.
Okay.
Yeah, you guys did good. Doesn't matter which goes first.
But you mentioned it does matter which one goes first.
It does or doesn't? Doesn't.
Doesn't? Okay.
No.
Okay. Got
Are
it.
you going to teach us Iranian?
Huh?
No?
What? About what?
You speak Spanish.
Yeah.
Yeah.
You speak Spanish.
No.
Any other
Any other
language?
language?
I understand.
Are you Hawaiian?
No, my parents are from Myanmar.
Where?
From
Miramar?
Myanmar. Yeah.
Where is Miramar?
It's it used to be called Burma.
Oh, Burma.
Yeah.
Okay.
And then yeah, it's in Southeast Asia.
Okay.
Yeah.
So you classify yourself as what?
Well, I guess I was born here, so I just
You're
Burma-
American.
Asian American.
Asian American.
Yeah.
Okay.
Yeah.
Okay.
Where's Burma?
But you
Oh,
could
Yeah.
you can classify. You could go for Hawaiian.
Oh yeah, I get that.
You get
yeah.
that one as
Yeah,
well?
I get that. Yeah.
Yeah, you
people
look
think-
like a good Hawaiian.
Yeah. 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 So.
All right. The last one. I don't think you had a hard time with this
Yeah,
one.
that
No.
one is easy.
What?
Papilloma. Squamous papilloma.
Yeah.
If you said Verrucous vulgaris,
No, vulgaris like it.
I would give you credit.
Really?
I would, because I think microscopy, you can't always tell the difference.
Yeah.
This one to me is squamous papilloma.
Yeah.
All right, I don't, you know, But-
Yeah.
you can't really, okay, give me your paper. You guys did good.
Okay.
Yeah.
You
Good.
did good.
Good job, you guys.
So you're getting the ideas, and what helps is just going over it and over it and over it.
Yeah, with pictures and
Yeah.
description and all that.
Yeah.
So there is no way that we have those PowerPoints with the picture. We need a picture of them.
Well, I'm gonna try to give those to you.
Okay.
Yeah.
For her too, or no?
For her too?
No, sorry.
No, I'm not gonna give you hers. I would. She
Her
would fire me
PowerPoint.
for that.
Her PowerPoint, the blue one, the
No,
light
I
blue one.
can't dare give
That's
you
nice. That
Man,
one.
I'd get my butt kicked from her if she would've found that out.
Just the pictures, not anything else. No? Goodness. Thank you.
But, but the pictures that I'm gonna show you, she uses my pictures,
Yeah.
so you're still gonna see them.
Yeah.
Really?
That's why you
Okay.
can't say anything.
Okay, we won't. We promise.
I don't say anything.
Just like you can't say anything when I show you the PowerPoints of those national boards.
Sure.
Remember I talked to you
Yes, you
Yes.
talk about it.
about it? I could get in trouble too.
Yes. We don't talk about anything.
You don't wanna get me fired, do you?
No, no, no.
If you get me fired,
We're not
who
trying
else
to
is
do
gonna
that.
teach you the rest of this quarter?
That's true. Yeah.
That's true.
I know, you go to your department chairman, you say, oh, Dr. Thompson, he is so
No.
hard on us. Man, why did you get him?
That'd be like the last thing we do.
Yes.
Yes.
Ever.
No, thank you. You're very helpful.
Well,
You know how
I'm
to explain
trying to-
things really well.
I'm
Thank you
trying
so
to,
much.
I think you're getting it. You're yours seem to be.
Yeah, Heidi is so
She-
good. Brian is so good.
Yours seem
And you're
to be
good too.
getting it pretty well.
I'm just a bad test taker. Like I can like explain it and tell you and stuff, but like actually, I don't know. Yeah, I wish it was
But
like
you
an
came
oral
up-
exam or something.
You came up with some good right answers today. Even when we
Yeah.
first started today, before we started anything,
Yeah,
you had
I like to go, but yeah.
you were hitting it right on. I mean, some of the trouble is we have so much information. We try to learn everything, and we can't, and then we get it confused.
Yes.
We get, oh, let's go to this restaurant. What's that? You know, we get all this instead of just trying to think of the few main
Yeah,
things
Miss
about it.
Hayton mentioned they're gonna make a decision to make it from 5 units to 4 units and then make it smaller. It's better.
Do what now?
They're gonna make a decision, the
Yes.
hygiene part, because this course is 5 units. So they're gonna decrease it. They're gonna make
So-
it smaller. That's a good idea.
Well, wait. How you going to learn the same thing in less time?
They're gonna do it with the juniors or the rest, not us.
No, but how would they teach the course in less time? You're saying there's too much information now.
They said.
So are they saying they're going to teach less information?
Yes.
Oh, okay.
Yeah, they said they're gonna make
Less
it smaller.
material?
Yeah, less material.
I think they should do like the basic ones that you will see
Right,
at
You
an
will see,
office.
yes, a lot in the
Right,
clinic.
right.
Yeah,
Like
not
I-
everything.
Yeah, like basal, like squamous cell carcinoma.
right,
That's like something
right,
you need
Right.
to like
No, I agree.
know.
Yeah.
And all that.
Yeah.
But
So do you have any other 5-hour courses?
No.
But
Just
again,
that.
though, I don't know if I'd agree with this, because you have to teach both general path and oral path in 4 hours, and I don't know how you can do that. Because see, it's not just oral path. You could teach oral path in 4 hours. It would be hard, because but to teach both general path and oral path in 4 hours, man, that would be tough.
Should we start general pad and ask questions if we have questions? I'm gonna start it from maybe this weekend. We have exam on November 8th.
Oh, November 8th.
Just ask if we have any problem.
I don't know what she's gonna, I don't know how much detail
It's
she's
6
gonna
chapters.
get, that she gets on that. Alright. Did, now,
There's no picture.
the other oral pathologist, Gandhi, she seems like a sharp teacher too.
Yes,
She seems like she'd be a good,
she is.
do you have a problem with her language at all?
No.
No?
No.
Okay.
Her words is okay. The She
I'm-
doesn't
I don't
speak
know
so
her very
fast.
well. She
Oh,
doesn't
really?
speak. No, she replaced me.
Oh.
So when I left, then they hired her. So I don't know her. I've only met her a few times.
oh god. No, yeah,
Yeah.
she was.
But I started here in 1970.
Well, we have a teacher like, I forgot his name, I'm bad at names, Head and Neck. He's older than you, but he's still teaching us. He still teaches.
Who?
Do you remember Head and Neck?
Yeah, what's his name?
Anatomy? I'm pretty sure
Oh,
he's
Dr.
older.
Nava.
Dr.
Nava?
Nava, yeah.
Yeah, yeah.
You're not on his age. Why he's still teaching us?
I
but
think
you,
he might have retired.
Yeah,
I
I think
saw
he was
him.
just like a part time.
Yeah, part-time
part-time.
professor. Yeah.
Are you saying I'm just not too old to teach?
yes,
No,
I
that's-
hear he retired.
No, did you see what she just said? You said I'm too old to teach.
No,
No,
you're,
you're
not.
Yes, I asked you if I'm too old to teach, and you said yes.
You are not too old.
But you said yes.
She takes it back.
Boy, when I grade your paper, it's going to be a lot different when I grade their paper.
I meant that you're not.
Oh, okay.
Yes.
But you know, you do, at least I do. I'm trying to get, I'm actually, can't remember words like I used to. They don't come to you like they used to. Words. I have a hard time remembering the words. That's starting to affect me. I see that. Or
Got
names of people.
Oh, people's name.
Yeah.
Got it.
I've seen him for here for 40 years. What's your first name? I did have a nice chat yesterday with our former dean, who you guys went around, Goodacre. You know who Dr. Goodacre is?
Goodacre.
White male.
Yeah, big, tall guy. He was our dean for years.
Is he still the dean now?
No.
No. Never
You mean who? Who's the dean now? Handysides.
Yeah,
Yeah.
that's why.
Handyside.
And who was the dean before Handysides? Daly. And you,
We don't know.
Yeah.
he didn't have Daly.
No.
Okay. And then Goodacre was many years before that.
Oh.
I worked under every dean here except the very first dean.
Oh, wow.
Really?
Yeah.
Did you ever get to meet the first dean?
Never met him. Never saw him. He started here a year before I entered school.
Oh.
They say he was really a good dean. The dean that I worked under, the main one when I started, he was a tough dean. Let me tell you.
Oh.
You guys, you wore a tie. When you were in this, always, you wore a tie when you were in the dental school. You never came in here without a tie on.
Wow.
Talking about men.
Yeah.
Even on Sundays, if you came to work in the lab, you wore a tie.
Wow.
Wow.
Would you get kicked out?
Yes,
Oh wow.
Wow.
yes.
How about the females? What for their dress code?
You know, what was interesting, the first female dental student was in my class, Marlene, a friend of mine. Could you imagine being the first female dental student with all the 60 boys?
Yeah.
Wow.
60
Huh?
boys. Wow.
Yeah. 60 boys and just one.
60
girl.
boys, one girl. But she can handle herself.
Yeah.
She was, I mean, we all thought, okay, wait till she gets oral surgery. She can't do extraction. She'll fail. But she was a smart gal and could handle herself. She was really young.
Yeah.
She was one of the youngest in the class. But she could take any kidding that we gave her, but she would give it back again.
Yeah.
You know, she was she was a friend to all of us.
Yeah.
She wasn't, you know. But the hard part came. Here's the interesting. Okay, when I button things up, my buttons are opposite than yours, right? The women's
Oh.
buttons go the other way.
Yeah.
So what did we? Our uniforms back then were the old type, and you may not be familiar with. Do you know what the dentists used to wear?
No.
These white smocks. They were white smocks that only went down to the waist, but they went across here and they were crew neck, and they snapped over here and they went down.
Oh, I
They
saw
snapped
that. I
down
saw-
here.
Yeah.
Yes.
I saw.
Well, so she said, well, wait a minute. How can I wear that? I have to have one that's going to be snap on this side and snap down on the left-hand side. Because that's how women's clothes were buttoned on the opposite side.
Yeah.
Yeah. So I don't know if she had, I don't know if she had one made for that or not, you know. But you didn't dare ever walk in
Yeah.
this, even on Sundays, you didn't come in here without a tie on.
Dang.
I mean, you never came with
But then it's
shorts.
Is high uncomfortable?
No,
No?
not once you
Okay.
get, not when you get used to it.
Oh, okay.
Oh, that's true, yeah.
You
Yeah.
feel someone choke you?
No.
Yeah,
No?
have to be like,
Okay.
no.
No,
Every
not,
time I see someone like be tie, I think you're
no,
gonna choke.
no, it doesn't.
No? Okay.
No, it doesn't. I mean, it can be, actually, it can feel comfortable. Yeah. I think maybe I told you, when I was a dental student, my wife was coming in the student entrance to bring me lunch, okay? And she was wheeling the baby stroller with a young kid in it, my first kid in it. And the dean happened to be walking out the door at the same time
Oh.
and said, "Who are you? Why are you here?" She said, "Well, I'm bringing my husband lunch." He said, "Follow me." Now, this was out at the student entrance. So he walked all the way around the front to the front entrance,
Oh.
and he said, "This is where student wives come into the clinic."
Ooh. Wow.
That's what it was like.
So you had to meet her at the
Yeah,
front.
yes, at the front.
That was tough.
Yeah, that was tough. That was tough. Yeah, it was totally different.
And
You-
you were
had-
teaching at the time, right? Or were
No,
you
I was a
student?
student.
Oh,
We were
okay.
students.
So, so you had no notes. You had no mimeograph notes. They didn't have mimeograph machines. You had no notes. The only thing you got information. You had to take all your own notes in class. There were no printed notes,
Oh.
none, because they didn't have Xerox machines. They weren't invented yet. So, the the teacher lectured, but you had to take notes for everything or read a book. So you had no printed notes like this. There were no handouts. You got no handouts whatsoever. So everything you learned to take notes. Yeah.
Were your tests also multiple choice like ours?
Yeah, the tests actually, the old way, they didn't have Xerox machine. So the way they had to make the test, they were printed, but they had an old mimeograph. You ever heard of mimeograph machine? When they typed it out, it was like a carbon paper, a piece, and then it was carbon paper. And if they made a mistake when they typed it, you had to go in and erase that one letter and put a new thing in it. Can you imagine typing a whole test that way?
Yeah.
Oh,
Yeah,
no
no.
little test.
And the exams were probably long.
Yes, yeah. So, I gotta tell you the favorite story though. This was when I was a junior, and there was a lab upstairs, which is now part of the clinic, but it was a junior lab back then. They remodeled. So I was taking orthodontics lab, teaching how to do orthodontics in the model. So we were all in the lab. We were working on making something for an orthodontic thing. So the guy sat next to me. His name was Joe. And so he took it up front to get it checked off. You have to get procedures checked off on the models.
Yes.
Well, he had gone a couple times and they said, no, you got to do it over. It's not right, not right. So he came back and he sat down. He said a couple of words and I'm not sure what it was. Okay? And then he stood up like this in the lab. He took those models.
Wow.
He threw them across the lab. They hit the wall on the other side of the lab and just broke.
Oh my gosh.
Yes. And that room went total silence. You could hear a pin drop. And we thought, that's the end of him. We'll never see him again.
Yes.
So pretty soon the instructor walked out of the room. We knew where the instructor was going. He was going to get the dean. All right.
Yes.
So pretty soon the dean comes in and says, come with me. So he went out with the dean. We thought, that's the end of it. The last thing we ever saw is the tail end of it. We'd never see him again.
So was he just frustrated in his
Yes.
He was just frustrated. He was so frustrated. But actually they didn't kick him out over there.
Oh.
Wait,
Oh,
was
they
he a
didn't?
student?
They
He
didn't.
was a student, right?
Yeah, he was a dental
yeah.
student. They didn't kick him out. Yeah. Yeah. So
That
he
was
was
a
an
good one.
older. He was a carpenter for years. He was about 40 years old.
Oh.
So he should have never taken dentistry. He was happy being a carpenter, but his wife wanted him to be a dentist. And he wasn't that interested in being a dentist. In the end, he worked for a few years as a dentist. And then the last thing, and he was my classmate, the last thing I heard, his last few years, he worked in a factory somewhere, doing something. He gave up dentistry. He should have never taken dentistry.
Wow.
Yeah.
Hey, when you guys on computers, let me ask you something. When you get to computers, can you get on the internet anywhere in the dental school?
Yeah.
How do you get on the internet?
You should attach to Wi-Fi from here. LEP, something like that.
Yeah.
I mean, you have wireless Wi-Fi in the dental school?
No, we
Yeah.
attach to the school Wi-Fi. Dentistry school or LEP something. You should go to the top when it has a dot and then like a triangle thing. Brian knows that.
Mhm.
Do you want to do for him?
Oh yeah. So are you not able
Do
to
you
get on
want
the
to? Do you
Wi-Fi?
want to need it?
Well, yeah, I can't get on the Wi-Fi. I can do it wireless.
Yeah.
Yeah.
I mean, I went over to the library yesterday, and this is a computer from the dental school.
Oh, okay.
I mean, this is their computer.
Yeah.
They gave me 5 years ago.
Uh-huh.
But even the library, they tried to attach me to the library Wi-Fi, and they couldn't do it.
Oh.
Why is that?
Well, I usually use in the library. I use the one that says Loma Linda University,
Yes.
and when I'm here, I use the one that says LLU.
Yeah.
Yeah, so I use the two different Wi-Fi's.
So to get into the Wi-Fi, you need to have a username. And
Okay,
the
I have
password.
now. I have a username. I mean, I have a username because I'm a faculty emeritus.
Yeah.
So I'm not. I'm a emeritus faculty. So all emeritus faculty still have usernames. I'm still my
Okay.
L. Thompson.
Yeah.
But I don't know if I can get on I mean, they couldn't get me on the, they didn't understand why. I can get on the library and I have a password to get in the library and do all that stuff.
Yeah.
But he tried to convert this over to get me on so I could do Wi-Fi in the library. And he said, I don't understand. We can't do it. I mean, he couldn't do it. They tried to do it. But I said, that doesn't make sense. Then he said, go home to your hotel. Maybe something's wrong with your computer. See if you can get on Wi-Fi in the hotel. Yeah, I had no problem at all. But they couldn't get me on Wi-Fi in the library. And they didn't understand why.
So just you don't get any Wi-Fi at all on campus?
No.
Okay.
So I'm going over, and I know Jeff over at the Dell.
Oh, yeah.
I know Jeff well.
Yeah.
Yeah, he said, I'm gonna go talk to him and ask him why.
Oh, okay. It might be like having to do with your login credentials, maybe.
Because
the Wi-Fi is working.
The number I still have for this, like to use this number still works when I get in the library. The number at the bottom down here.
Oh. Because I know that every few months they make you change your password.
Yeah.
And then so every time it's different.
Because my email, I have an email password from my email.
Oh, to log into your
email.
school email?
Yeah, I can get onto that.
Oh, okay. Yeah, it should be the same.
But I can't get onto it because I can't get
onto the
Wi-Fi. Yeah, so I'm gonna go talk to Jeff and see what he says.
Okay. Interesting.
All right. Will you guys be good? And
Yep.
we'll see you tomorrow here.
Yep.
At 1 o'clock.
1
right?
o'clock, yes.
1 to 4. And actually tomorrow will be free. And then tomorrow you have a test.
Yeah, it's the skin and
You have the
oral
test.
infection
It's on what? Oral infection?
and it's skin disease post quiz, and then pre quiz is pigment lesion.
Post quiz on what?
Pigment.
Oh yeah. Pre quiz on pigment.
Pigment, yes, and then post quiz on skin
infection.
and oral infection.
Yeah.
Skin disease too in the
Oh,
mouth.
skin. Is it?
Both of them.
Oh, both of them.
Both.
Well, so we did both of them.
Yes.
Oh, okay. So it's on both. I don't
Yeah.
take that for sure.
Okay.
All right. And we take those at the end, right? Today.
I'm not
Right.
sure. I forgot. Did we
Wait.
take it in the beginning?
Oh, we took it all in the beginning.
Oh, you did? I'll
Yeah.
bet again.
Yeah.
Okay. Will you guys be good?
All right.
Alright,
Thank you.
bye, thank you.
And let's so like I said, right? The game at 7:30. Yeah. No one's even like we need to.
So do you have clinic today?
Yeah.
Oh, okay. Yeah. I have I'm gonna try screening patient today.
Oh, nice.
Yeah. Yeah. Do you have clinic today or?
Yes, I do, but my patient doesn't have anything. No picture, no note, nothing.
Oh. Oh, that's a screening patient.
Really?
Yeah, it's a brand new patient?
I don't know. How I can figure it out?
But you can check it out right now if you want.
I checked last night.
Oh, you did?
How I can figure it out is a screening or is a patient?
I think they should say screening too.
No, they didn't. But
Didn't?
do patient?
But they don't have x-rays or health
nothing,
history?
nothing. No picture, no health history.
Oh yeah, that's definitely a screening patient.
It's like a new patient for sure.
Yeah. Because you have to,
With the new one, I have to make the health history. I have to go to the FMX. It's a lot of work.
oh yeah. Okay.
Epithelial.
Oh, I haven't started yet.
Me too. It's 400 slides.
400 slides?
400 slides.
I'm not doing anything with this.
Yeah.
Sure, we have two midterms.
What's our other midterm?
The midterm. But it's not that bad, it's just 3 chapters.
Oh.
It's not that bad. But the stereo, it's like the last quarter that we had a webinar.
Oh yeah, Dr. Parsi.
Yeah, that's
Parsi, yeah. Okay. Oh, I think, yeah, okay. Yeah, see ya. I'll probably get something to eat. Yeah, alright, I'll see ya.